So, very warm good afternoon to all of you on behalf of IAPS, and it's a great opportunity for us to come together, and we would like to thank IAPS office for coming up with such kind of innovative conference called IAPS-Abhimanyu, wherein we are having students from different specialities coming together, and I'm sure it will be a great academic feast for all of us, and it also will help us to know each other better. So, without further ado, I would like to invite Dr. Ramesh Babu, sir, President IAPS, to give the opening remarks, and then we can begin the sessions.
Yeah, it's so nice to see all of you coming together today. And I wish you all success and then all the best for the prizes. I'm sure this program will become a big hit, and then in the years to come, we'll have more of such participants. Please start. Thank you.
Thank you so much, sir. So I'll hand it over to Abhirami to coordinate the first session. Over to you, Abhirami.
Okay. So, good afternoon, everyone. So, we'll be starting, and session one will be gastrointestinal surgeries. So, session one will be from Sri Guru Ramdas Institute of Medical Science. The presenter will be Dr. Sargam Verma. And over to you, the presenter. You can start your presentation.
To the presenters, you please be on time because this being a award session, you will be marked accordingly. Welcome,
good morning,
co-chair Dr. Krishna Rao. Okay, Dr. Sargam, you may start, please.
Thank you, sir. Good morning, everybody. My topic of presentation today is delayed presentation of jejunal atresia, type 3A with jejunal-ileal fistula. So the introduction says intestinal atresia is a congenital abnormality where there is significant stenosis or complete absence of a portion of the intestine. Ileal and jejunal atresias are usually described together as jejunal-ileal atresias. Jejunal-ileal atresia is a common cause of intestinal obstruction in neonates. It is seen in 1 in 5,000 to 1 in 14,000 live births. About 33% of the affected children are born prematurely, and incidence is distributed equally in both sexes. Less than 10% of the cases of jejunal ileal atresia are seen with extra-abdominal organ abnormalities, and this has been attributed to late occurrence of the localized vascular compromise intrautero. Very few cases of late presentation of type 3A jejunal atresia beyond the neonatal period have been reported. This case presented at 6 months of age. So the case report. A 5-month, 22-day-old female baby presented to our center with the chief complaints of vomiting, irritability, decreased feeds, and inability to pass stool since 2 days. The vomitus was described to be yellow greenish color, multiple episodes, gradual onset, non-projectile, and non-blood stained. The baby was delivered by LSCS at term with a birth weight of 3,900 grams. She cried immediately after birth and was breastfed within the first hour after delivery. The mother started antenatal clinic at 12 weeks of gestation and made 5 visits and received supplements according to the national guidelines. She was tested negative for HIV and syphilis. Mother was normotensive with normal blood sugar levels. No history of NICU stay after birth. There is history of hospitalization at 6th day of birth for neonatal jaundice. On examination, the baby was conscious, active, irritable, no jaundice, and her vitals were within normal limits. Abdominal examination showed symmetrically distended abdomen, hypertympanic percussion note with exaggerated bowel sounds. The rectum had little soft fecal matter. Subacute intestinal obstruction was suspected, and abdominal ultrasound and erect abdominal X-ray was done. Abdominal X-ray showed dilated bowels with multiple air fluid levels. Abdominal ultrasound showed prominent bowel loops to 2.5 centimeter in caliber and multiple lymph nodes along mesentery. CCT whole abdomen suggestive of small intestinal obstruction transition point in the distal loops, mesenteric lymphadenopathy, and dysmorphic small size spleen. She was kept nil orally, given IV fluids, and scheduled for an emergency laparotomy. These are the X-rays showing the multiple air fluid levels. Next, please. Management. The patient underwent exploratory laparotomy. During exploration of the bowel, intraoperative findings, proximal dilated jejunal end having narrow pinpoint communication with distal segment 10 centimeter distal to narrow atretic segment. Distal atretic segment connected to the narrow site with fibrous band. A small V-shaped mesenteric defect between atretic segment seen at the narrow jejunal ileal junction site and a long band attached to the same site continuing till splenic flexure. Proximal and distal bowel decompress. Bowel discrepancy 4:1. Proximal distal 15 centimeter distal segment resected till junction of narrow communication. Bands and other adhesiolysis was done. Proximal and distal segment anastomosed in 2 layers after chelating distal segment to compensate the discrepancy. Distal segment 80 centimeter normal, appendix and cecum free floating and healthy. Postoperative child was kept in ICU for observation. Strict NG aspiration, blood FFP transfused, intravenous antibiotics and fluids continued. After minimal NG secretions, feed was started on day 5th and child passed stools on day 7. NG removed, oral feeds were started and child discharged in satisfactory condition. These are the intraoperative findings where we see on the right side there is bowel discrepancy of 1:4 and on left side we see that junction where there was V-shaped mesenteric defect. Next please. So the discussion. Intestinal atresia is the most common congenital anomaly of small intestine with an incidence of 1:3:2:9 cases per 10,000 live births. Different theories have been described regarding the etiology. Most accepted etiology for jejunal ileal atrasias was proposed by Lowe and Bernard, which relates to the late intrauterine mesenteric vascular accidents, including volvulus intussusception, snaring at the umbilical ring, kinks, and bands. Our patient was born at full term. So the previous slide. Our patient was born at full term by LSES having a birth weight of 3.6 kg. She was started on breastfeeding on day 1 of the life, which she tolerated well and passed meconium on the same day. The child remained asymptomatic till 6 months of age. The clinical features of underlying pathology manifested only after weaning was initiated. At no point in time she had clinical features suggestive of necrotizing enterocolitis. To the best of our knowledge, the communication of the blind loops of the congenital intestinal atresia through EEF has not been documented previously. The cause of the congenital atresia may be any of the late intrauterine mesenteric vascular accidents, including volvulus intussusception, snaring at the umbilical ring, kinks, and bands. Thank you.
So Dr. Sargam was on time?
No, she overshot the
5.5
time.
minutes.
Sorry?
She overshot the time.
Okay. Okay, can we, Dr. Sargam, I'll start with the first question. Well presented, Dr. Sargam.
Thank you,
When you reviewed your literature, did you come across any definition as to how this delayed presentation has been described in literature? Like what is early presentation, what is delayed, or any kind of time limits?
Yes, so usually in these cases, in jejunal ileal atrasias, the neonate presents in like 1 month, in 1 month of age. So they are mostly operated in the first month of age only. And we have very less incidence of this findings, like in 6 months of age. There are like 3, 4 articles that I came across of the similar cases happening.
Okay. So what I mean is there any such description as very late, delayed, very
No,
delayed?
sir.
Nothing. Okay. Great.
No.
So why did you do the CT scan in this case? Did it give any additional information? Before I'll ask my coaches to ask you further.
Sir, it did not give any different viewpoint for that, but the
Okay.
patient was already being treated at various centers, so he came with all the investigations to our center.
Right.
He
Fair
was
enough.
already having all those
Yeah,
investigations.
understood. Fair enough.
So, Dr. Sagam, do you suggest CT in a newborn? Is it advisable?
No,
Or can
ma'am.
you? Okay. So, what are the other modes you, if the child was born in your center with or presented to you, what are the investigations you like to do?
Ma'am, if the child was born in our center, ma'am, during the gestation period, only we could do the anomaly scans for that.
Okay.
And ma'am, when the child is born, we can assess the child totally, and we can also counsel the mother about all the symptoms that can happen in congenital anomalies.
Okay.
Ma'am, rest, I think if the child is presenting very late, so there might be a problem with the diagnosis, because I think in small centers, we don't have all the facilities, and we don't have like the super specialist pediatric surgeons that we have are in our center. So diagnosis was delayed, maybe because of that.
Would a contrast study would have helped?
Yeah, sir, definitely. It could have shown us the point of
Transition.
stenosis where it was. Yeah.
So how was the post-operative period? Like, when was the child discharged? How long it take for the recovery?
My child was discharged on day 12th. So
Okay.
for first 5 days, we kept it totally NPO.
Okay.
Everything was going IV nutrition, and then ma'am feeds were started on day 5th. Matlab after day 5th. So
Okay.
ma'am, child was accepting the feeds well, and then ma'am, she passed stool on the day 8th.
Okay. What is the follow-up period till now you have for the child?
Yeah, ma'am, the child present after ma'am follow up. He came 2 times. She came 2 times with the family. Ma'am, she was flourishing well. She was very active. The wound was healing very good, nicely, and she was taking feeds and she was passing stool.
Okay. Okay. Nice presentation, Dr. Sargam.
Thank you, ma'am.
Can we move on to the next presentation?
Yes. So the next presentation will be by Dr. Pravalika from RK Hospitals. So over to you, over to the presenter.
Good morning, Madam and Sir. I'm Dr. Pravalika, Pediatric Resident from Omni
If you have joined through multiple devices, you need to have one device only switched on.
Yes.
Otherwise, we are getting a very bad echo. Yeah.
Good morning, sir. I'm Dr. Pravalika from Omni RK Hospitals, Vizag, and my pediatric surgeon is Dr. M. Srinivas Rao, sir. Today, I'm going to present a case of formifrostic choledochal cyst presenting as multiple cholelithiasis. Now we'll discuss about normal anatomy. Here, right hepatic duct, left hepatic duct fuse to form common hepatic duct. Cystic duct joins with that to form common bile duct. Common bile duct joins with main pancreatic duct to form common hepatico-pancreatic duct, and it drains into duodenum. In normal choledochal cyst, usually there is cystic dilatation of the extrahepatic biliary duct. But here in this formifrostomies, there is incomplete manifestation of the disease and there is no dilatation. The issue here is there is pancreatico-biliary malunion forming long common channel. Hence, it also known as long common channel syndrome, and usually common channel measures around 2 mm, can go up to 5 mm, but here in our case it's around 10 mm. So case study, we presented a 2 weeks old neonate presenting with the chief complaints of ecolic stools, progressive jaundice since birth. On examination, child was having abdominal distension with hepatomegaly. Investigations were done. LFT shows obstructive pattern, and we ruled out other hemolytic disease. Ultrasound abdomen was done, which showed multiple liver abscesses with cholelithiasis and dilated intrahepatic biliary ducts. And MRCP was done and confirmed above findings. Here, it's a dilated pancreatic duct, dilated CBD, and there is long common channel. So this is the intra-op finding. So we have planned for laparoscopic excision of the cyst and hepaticoduodenostomy. And cyst was excised and it was sent for the biopsy. Biopsy findings confirmed the presence of choledochal cyst. And these are pre-op LFTs and post-op LFTs. In pre-op LFTs, there is a bilirubin above 5 and its more direct component is more than 20%. And post-op LFTs, there is dramatical decrease in the bilirubin levels. And there was transaminitis earlier, and transaminitis was reduced in post-op LFTs too. And the conclusion here is formifrostic choledochal cyst usually presents in the older children, that too in pediatric age group, as pancreatitis. But here in newborn presenting as cholelithiasis is very rare and uncommon. Initially, we had a suspicion of extrahepatic biliary atresia, but we have done MRCP and ruled out it. And rarity in newborn and dramatic disappearance of symptoms after surgery are the salient features of our patient. Thank you, sir.
She finished on time.
Dr. Krishnara, you may take the lead in asking.
Yeah, it's a nice case. It was actually a choledocholithiasis, right? She was feeling as a cholelithiasis.
There was cholelithiasis too, sir.
Okay.
Uh,
And
so
the patient had also the stone on the CBD, right?
yes, sir.
So it's called cholelithiasis with choledocholithiasis.
Yes.
Okay. So hepatico-duodenostomy was done in this surgery
Yes, sir.
with cholecystectomy.
Yes, sir. Choledochal cyst excision with hepatico-duodenostomy was done, sir.
Okay. When did you start orally for this patient?
We have started on day 5, sir. After 5 days.
Okay. Okay, fine.
Okay. So, Doctor, you mentioned a very nicely managed case indeed. Suppose in this case there was no reason to delay. Definitely, the child merited an exploration and a definitive therapy was on cards. What would you have done differently if suppose this case was an antenatally detected case with a kind of formifrostic-like picture, not fitting into the traditional CB choledochal cyst with some minor dilatation. Of course, MRCP might show you the malunion at the bottom. So what would be different if that would have been the scenario, Dr. Pravalika? Jaundice, suppose there's no jaundice also, because what I mean to ask is when do you would recommend, or what have you read in literature about the timing of surgery? Is it clear cut mentioned? Is there anything?
No, sir. Usually,
Especially for formifrostic variety.
yes, sir. Usually it presents in the age group around pediatric age group around 4 to 10 years time, sir. But here by birth, the child presented with ecolic stools and persistent jaundice.
Understand,
So
yeah.
we have, based on the clinical complaints, we thought initially we had a suspicion of extrahepatic biliary atresia case, but our surprise we found it as a choledochal cyst FFCDC, which is a rare manifestation in this age group.
Thanks, Pravalika.
Thank you, sir.
Any questions from the audience?
I don't think so.
Okay, then
In the
we'll.
chat box, let me check. No,
Dhanan.
not for this particular case.
Okay, sir. So we'll be moving to the next presentation, which is also from the same presenter. So you want to proceed?
Yes, ma'am.
Yes.
And the second case is pyloric atresia case in newborn, diagnosis and surgical intervention. And here is the case study. It's a term baby presented and it's delivered by LSCS in view of polyhydramnios and presented with abdomen distension and vomiting on 3rd day of life to our hospital. And the baby didn't pass stool, and we have done X-ray erect abdomen, and it shows the single bubble, and clinical diagnosis of pyloric atresia was made and parents were counseled and the baby was subjected for laparotomy. In intra-op findings, the solid arrow shows it's the stomach opening, pyloric end, and this the lighter one, this arrow shows the duodenal opening, and this whole long is the atretic segment, and there is distended stomach. So here we have excised the web and pyloroplasty was done. So post-op period, baby had high bilious aspirates, and we have subjected to dye study on post-op day 7. And there was this is after 5 hours of the dye study, and there was persistence of the dye in the stomach. And so we have planned for second laparotomy on POD 8 with gastrostomy and feeding jejunostomy was done. For next 2 months, baby was continued through jejunostomy tube, and baby is yet to follow up. So conclusion is that it's a pyloric atresia is a congenital gastric outlet obstruction. Incidence is 1 in 1 lakh, very rare presentation, and diagnosis is easy but difficult to manage as in the post-op period, as there is delayed gastric emptying, which is seen in our case. Usually it is associated with epidermolysis bullosa, which is a cause of sepsis and mortality. And post-op feeding is the priority, is the main, we should emphasize on post-op feeding, which is the priority of treatment of pyloric atresia. Thank you.
She finished on time.
What was the electrolyte status pre-op in this case?
Sir?
What was the electrolyte status pre-op in this case? Any abnormality was there because of gastric outlet obstruction?
No abnormality was there, sir, in electrolytes.
The baby presented with non-bilious vomiting?
Yes, sir. Non-bilious
It
vomiting.
should be like same like
IHP.
infantile hypertrophic pyloric stenosis, right?
Yes, sir.
Okay. How long it take to completely resume to the full feeds for this child, oral feeds?
Sir, it took around 2 months time for us, sir. Because initially we have waited after first surgery, we have waited for 7 days. But child didn't pass stool and there was abdomen distension, and also we have thought for revision surgery.
Any total parental nutrition was given, TPN, anything for this child?
Yes, sir. Initial 7 days we have given, sir. Later, when we have established jejunostomy feeds, the child was tolerating, baby was tolerating well. Continued on jejunostomy feeds, sir.
Doctor,
Okay, thank you.
Doctor, thank you. Dr. Pravalika, just one query. In fact, one would be a carryover question from what Dr. Krishna asked. It's about, or let me ask the other question first. You at some point of time you mentioned the web, and then the topic of your presentation is pyloric atresia. So I don't think they will be in the same particular case. I mean, they are two different entities. So pyloric atresia will not have a web. Atresia would be like it is totally would have no lumen at all. So if you have excised the web and done something, I doubt whether you can label it as having pyloric atresia. That is question number one. Second is, why not, or in retrospect, do you think gastrojejunostomy would have been a better choice? Did you get my question, Pravalika?
I got your question, sir. So there was a atretic segment only, sir.
Oh, but you mentioned excision of web or something. So fine, that's all right.
Segment only.
And about the second question, doing gastrojejunostomy or some other kind of procedure?
Yeah, we could have it. There is a possibility that we can do, sir, but our pediatric surgeon and our team opted to do
Yeah,
this.
that is absolutely, I mean, that's another option that could have been done, right?
Done.
Okay.
Do you think of any differential diagnosis preoperatively with that X-ray? And also, what was the nature of the vomitus child had?
The nature of the vomitus is non-bilious in nature.
Okay.
And baby had abdomen distension, and also clinically we thought it could be pyloric atresia case.
Okay, so you didn't have any differential diagnosis preoperatively?
No, we didn't had.
Okay, okay.
Because the emesis is non-bilious.
Okay.
We have one question in the chat box. Have you heard about Jodhpur disease entity?
Sir?
Jodhpur disease.
No, sir.
Not an issue. Just go
No, I
back
haven't
and
heard.
yeah. Very similar to your case, but slightly different presentation. I think we can go on to the next case then, next presenter.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
So the next presentation will be by Dr. Kritika Rangasamy, and they'll be presenting from Kobe Medical Center, Coimbatore. Can we have the presenter?
Yes, ma'am.
Kindly share your slides, please, Kritika.
S number है Kritika. Kritika A4. Ma'am, I'm finding difficulty to share my screen.
Dr. Vinek, do you have the presentation? Can you share it quickly?
Yes, ma'am, I'm sharing.
Kritika, your screen was visible.
Yes, sir, but
You just need to click on share, and then you'll have to minimize it and then open the presentation in your iPad. I think you're using your iPad.
yes, sir.
You go to your presentation, minimize this thing. Yeah.
Yes, sir.
Understood.
Good afternoon, sir. My name is Dr. Kritika. I'm a final year resident in obstetrics and gynecology from Kobe Medical Center, Coimbatore. I'm here presenting a case of a jejunal ileal atresia, a type 3B type with the bowel ischemia from a prenatal diagnosis to the postoperative management. So here is our case, a 26-year-old preemie who underwent an anomaly scan which showed a short segment of fluid-filled dilated small bowel loops measuring 10 mm with echogenic walls and to and fro peristalsis and no other anomalies. She underwent genetic evaluation which showed a heterozygous pathogenic variant in the CFTR gene, which is less likely to be the causative pathogen. For the follow-up, increase in the small bowel loop dilatations were observed with increasing amniotic fluid levels. A male baby was delivered via emergency cesarean section at 36 weeks due to obstetric indication. Baby presented with abdominal distension and bilious aspiration after birth and had a difficulty in respiration with acidosis. Immediately, the baby was resuscitated and intubated, and a pre-op X-ray on the day of birth, it showed a triple bubble sign, which is suggestive of a jejunal atresia. Planned for emergency laparotomy on the day of birth. Intraoperative findings were about 30 centimeters of the normal bowel remaining from the DJ flexure. Entire ileum tottered over the ileocolic vessel with in utero volvulus. Perforations with calcification and gangrenous bowel seen up to 2 centimeters from the ileocolic junction with multiple adhesions and meconium peritonitis, which is a kind of type 3B deformity. Proceeded with small bowel resection and end-to-side jejunocolic anastomosis with venting ileostomy. Child was doing postoperatively well. Regarding a discussion part in the jejunal atresia, it is a widespread cause of neonatal intestinal obstruction, which happens secondary to the intrauterine mesenteric vascular accidents. The incidence is 2.1 per 10,000 births. As jejunal atresia can affect multiple lengths of the bowel, the severity increases with advancing type of atresia. It can be classified into 4 types. Prenatal diagnosis is quite challenging, but with advancing technologies, the ultrasound features of dilated bowel loops more than 7 mm and neural thickness of more than 3 mm with polyhydramnios could be suggestive of small bowel atresias. Postnatally, clinically, baby presents with bilious vomiting, abdomen distension, delayed or absent passage of meconium, and radiologically, double or triple bubble sign will be seen in X-ray. Intervention, primarily surgery, aiming to restore the intestinal continuity and function. So type 3B jejunal atresia is rare, which occurs for 11% of the total small bowel atresias, and among which only 50 to 20% chance of bowel ischemia or necrosis will be seen, as seen in our case. Complications such as sepsis, small absorptions, short bowel syndrome strictures can be seen, which are to be monitored and treated supportively. Conclusion, prenatal diagnosis is crucial because parents can be counseled appropriately. Detailed examinations can be performed to exclude other malformations or syndrome, as jejunal atresia is associated with cystic fibrosis, and delivery can be arranged in a center with appropriate facilities. However, the outcome depends on the gestational age at birth, exact position and the size of the defect of the bowel, and the associated complications like sepsis and the short bowel syndrome. Thank you.
She finished on time.
Yeah, a difficult case to manage, Dr. Kirtika. Can I start with the questions, Dr. Abhimanyus?
Sure.
So tell me one thing, because this case was having an antenatal detection and you also did genetic study. Suppose the parents are now have a query about the chances of having the disease in subsequent pregnancies. So how will you counsel them?
Sir, it is an autosomal recessive condition. So we have to counsel based on that. So it doesn't have much association with other syndromes, sir. The main syndrome is which
if they ask about the next child also having the disease, if they ask specifically, what will you answer?
Sir, that's why we did the genetic evaluation in the antenatal period, sir. And we saw the karyotypes and the fish and everything were normal. And in the CFTR gene analysis, that showed a variation. It is a heterozygous variation, but it is doesn't. It was not a pathogenic variant, sir.
Okay.
How much length of bowel was viable at the time of resection anastomosis during the surgery?
30 centimeters from the DG flexure, sir.
Okay. Does the child require any additional nutrition like
yes, sir, the
parental
baby
nutrition
was on
for this child also?
Yes, sir. The baby was on TPN initial 5 days, and it was started on oral feeds with the slow rate at 1 ml on 6th day. And it tolerated for few days, but later the baby had again abdomen distension and the electrolyte abnormalities were there, which were managed accordingly, sir.
Okay, now the baby survived, and how long you are in follow-up with the child?
The baby was in our ICU for the 3 weeks, sir. But after they went against the medical advice because of financial issues, so the follow-up was lost, sadly.
Okay. With 30 centimeter bowel and without the bowel will not be sufficient to manage the baby to survive, I think.
Yes,
The baby might have succumbed later on.
Yes, sir. Yes, sir.
So, any more questions?
Just
presentation?
a last question, if there's time, if it's allowed. Dr. Kirtika, any other specialities you would have involved? Suppose the child would have a longer bowel and the child would have made, suppose the child comes out well, doesn't have a short bowel syndrome like this case. Would you have approached any other specialities for a multi-modality care?
Yes, the baby would have having deficiencies like vitamin deficiencies and B12 deficiencies because of this restriction, and further follow-up regularly should have been done for a long-term approach in correcting the deficiencies and everything.
Something for the CFTR gene also. Child might manifest features of cystic fibrosis.
Yes, sir. Yes, sir. So pulmonary involvement also we have to follow up and
Thank you.
Thank you, sir. Thank you.
Can we move on to the next presentation, sir? Okay, we'll be moving on to the next presentation, which is presented by Dr. Ajay Kumar from Jawaharlal Nehru Medical College. So over to Dr. Ajay Kumar. So your screen has been shared. Yeah, please.
Thank you. Good afternoon, everyone. I'll be presenting a case of nesidioblastosis, which were managed by total near pancreatectomy, who were presented in neonatal period, and we'll be discussing about the outcomes of this surgery. So the aim of this study was to study the challenges of the surgery that is near total pancreatectomy. And the period was from 2010 to 2023, in which 4 neonates were enrolled. 2 were males and 2 were females of 24, 27-day old and 26-day and 28-day old. They presented with hypoglycemia, and after excluding all the causes of hypoglycemia, they were diagnosed with necidioblastosis. The investigations done were provisionally the USG and in some cases a contrast study of CT. And initially the medical management was done, that is a continuous IV infusion of dextrose followed by hydrocortisone to prevent the complications of hypoglycemia, and hydrochlorothiazide diazoxide and octreotide to prevent the insulin secretion. So after managing with medicines and coming to the diagnosis of necidioblastosis, they were taken up for surgery and planned for near total pancreatectomy, in which the tail, body, and part of the head of the pancreas were resected, reserving along with the spleen part of pancreas along the spleen and splenic vessels. So these are the clinical feature photographs where there are 4 neonates, and the fourth one, which was a redo surgery, we can see the previous mark already present here. These are the intra photographs where we are showing the pancreatic specimens which were resected, mainly here. And the last photograph here, which was the redo surgery, and part of the pancreas tissue which were remaining was removed. The last photograph. So the post-operatively, the blood sugars came to normal values, and the drugs were tapered off completely in 2 patients and late in another one. And one patient required prolonged medications with diazoxide and octreotide, and one redo surgery was required, which I have mentioned. The histological examination of these specimens revealed diffuse hyperplasia of pancreatic cells, and 3 babies are doing well clinically and neurologically at follow-up. One patient is lost in follow-up. So these are the post-operative photographs. So coming to discussion, necidioblastosis, also called as PHHI, persistent hyperinsulinemic hypoglycemia, is a manifestation by age and severity of the hypoglycemia. We all know the features of hypoglycemia, mainly jettiness, lethargy, cyanosis, and decreased activities. Severe forms can also cause neurological dysfunctions, and the management of these complications is very important and has to be done on an urgent, immediate basis. So there are different types. One is transient type and one is persistent type. And the mutations which are known to occur are in sulfonylurea genes and potassium inductase reductase channels. So which are mainly used, which are mainly for the function of structural and functional functions of the insulin and its management. So investigations, the highlight of this investigation is we have to demonstrate the elevated levels of insulin during the episode of hypoglycemia. So which was done in this case, and other supportive investigations would be low levels of free fatty acids and ketone bodies. And other added investigation would be patient requiring continued insulin infusion even above 10 mg per kg per minute. So suggestive of hyperinsulinemia. So management, they usually suggest shorter feeding intervals with multiple feeds and continuous feeding through NG tube and IV intravenous dextrose infusion. Hydrocortisone, as I mentioned, to prevent the complications of hypoglycemia. Diazoxide medicine, mainly it is used for the adverse effect of this is used for the treatment of this. And we have to keep in mind the other side effects, that is dyselectrolytemia and hypotension. Octreotide, the main drawback is the patient can develop resistance, and glucagon infusion can also be done, and calcium channel blockers like nifedipine can also be used. So the persistent type, as I told, the genetic mutations which occur here, and the investigations which we can do is CT, USG, CT, and in some cases MRI have to be needed. The gold standard investigation is PET DOPA, which shows focal and diffuse area both, and they can diagnose with 96% accuracy. So here we can see a photo which shows uptake of the dye, and usually the last resort is total pancreatectomy. Achieving complete pancreatectomy is sometimes very tough, and sometimes we end up with the 98% of the tissue being removed. And development of diabetes mellitus in is almost 14% in mean time for 9.6 years. So to conclude, early onset forms of this nesidioblastosis, which is resistant to medical therapy, and the neurological sequelae are related to delayed diagnosis and delayed surgery. Hence, it is very important to diagnose early and aggressive treatment and early counseling for pancreatectomy. So the latest advancement in this surgery is what is it called as cryopreservation of islet cells when you do pancreatectomy, and at a later date, which they are transfused, islet cell transplantation. And this drawback of diabetes mellitus in 14% can be negated sufficiently. Thank you.
He has overshot the time by 2 minutes. We can have just one quick question.
Doing a near total pancreatectomy, don't you think it's like too radical for the nesidioblastosis?
Yes, sir. Near total pancreatectomy is very radical, and it's very difficult also. But we can still achieve that. And the better safe advice would be there are three options: 95% pancreatectomy, 98% pancreatectomy. Even 98% is sometimes useful, but the chances of recurrence and relapse are more in such cases.
Quick question,
Okay.
Dr. Ajay. In your discussion, you had mentioned the role of genetic testing and PET scan, dot not. How
Yes,
many how many of your cases had undergone these tests, both either one of them or both? Because that really helps
sir.
us decide whether we are dealing with nesidioblastosis or a focal lesion.
Sir, DOPA PET was not done in anyone. It is just a part of discussion I mentioned. The mainstay, the manifestations which we did was USG, and in one patient, CT was done.
Genetic testing also was not done.
No, sir, genetic testing was not done
Alright, we
because.
have overshot the time already.
Yeah.
Thank you, Dr. Ajay.
Yes, sir. Thank you, sir. So we'll be moving on to the next presentation. We still have 15 minutes for the half of the session to run. So the next presentation will be by Dr. Janvi Sirwani. She'll be presenting from AIMS Bhubaneswar. Over to you, doctor.
Ma'am, am I audible?
Yes, you are.
Okay. Good afternoon, everyone. It is my pleasure to present our research titled Clinical Profile Outcomes Predictors of Mortality in Neonates Operated for Congenital Gastrointestinal Anomalies in Tertiary Neonatal Care Unit, an observational study which was conducted in AIMS Bhubaneswar. Congenital gastrointestinal anomalies in neonates present significant challenges ranging from simple conditions with good outcomes to complex malformations requiring urgent surgical intervention. Our study basically aimed to explore the clinical profile, outcomes, mortality predictors, and in neonates undergoing surgery for GI anomalies, providing insights into factors that impact survival. This was a retrospective study conducted at a tertiary neonatal care unit from January 2019 and July 2024, in which we collected data of 78 neonates with congenital gastrointestinal malformations, and data was collected from NNPD and birth defects database. In this study, we included 78 neonates with conditions such as anorectal malformations, tracheoesophageal fistula, and Hirschsprung disease, and others. We systematically analyzed baseline characteristics, surgical outcomes, post-op complications, and mortality predictors using appropriate statistical methods. Among 78 neonates, 59.2% were male, 42.1% received antenatal care, among which 23.6% neonates were detected antenatally. Antenatal detection rate was highest among omphalocele, followed by duodenal atresia. Also, the mean gestational age was 35.8 weeks and the mean birth weight was 2360 grams. And we also found that 21% of the neonates had associated anomalies, and amongst which a tracheoesophageal fistula had 42% associated anomaly, that is bacterial anomaly. Also, we found that only 68% neonates underwent surgery at an average of 7.4 days after birth. About 35% received total parenteral nutrition for average of 17.8 days. resulting in mean hospital stay of 13.6 days. Also, the overall mortality rate was 22%, with highest mortality observed in cases of omphalocele, that is 75%, followed by tracheoesophageal fistula, that is 43%. These results emphasize the complexity and severity of these conditions. Also, we identified three mortality predictors, that is low birth weight, weight less than 2000 grams, leading to 76.4% mortality, gestational age less than 34 weeks, that is prematurity, and sepsis was also found to be a significant mortality predictor. These findings highlight the importance of early diagnosis and multidisciplinary management in improving outcomes for these neonates. Also, antenatal detection rate allows for better planning and intervention. Moreover, preventing sepsis through robust infection control in NICU is essential for enhancing survival rates. To conclude, our study indicates that survival of neonates with surgically correctable GI anomalies is promising with early intervention and optimized care. However, low birth weight, prematurity, and sepsis significantly increase the mortality rate. Thank you so much, everyone, for your time. I would like to welcome any questions. Thank you.
She finished on time.
It's a very good presentation, doctor. So there's a question in the chat box, like if is birth defects, is it institutional or integration with some national agencies?
Birth defects data, it is institutional, ma'am.
Institutional only. Okay.
Yes, ma'am.
So what was the period? I'm sorry, I missed it. So when
Ma'am, period was January 2019 to July 2024.
okay. So everything was retrospective.
Yes, ma'am. Retrospective chart review was done.
Okay.
Dr. Janvi, a very nice presentation and nicely conducted study. Just one query as to what was your objective, because I think you have missed a slide. Otherwise, you have presented and told us everything related to the study, because unless you have a clear-cut objective, your results should also reflect in those lines.
So
Now that
our
you know the
objective,
results, can you tell us in brief what would have been your objective statement?
our objective was to identify the predictors of mortality so that
Yeah, so
in
that was
future we
missing in the
can.
presentation. Absolutely. That's what is coming out very nicely, but should have been there in your presentation. Directly from one before, I think the result slide on that should have been there. Agree?
Yes, sir.
Yeah. Nicely presented. Thank you.
Thank you, sir.
If there is no more questions, can we move on to the next presentation? We like the audience to add in with some chats and chat box questions, which the presenters will be answering. Due to the time constraints, we'll be moving to the next presentation by Dr. Asha, and she'll be presenting from Institute of Medical Science, some hospital. Over to you, Dr. Asha. Dr. Asha, you able to share your screen, please?
Please unmute yourself.
I'm not able to share, sir. If anyone from the other side.
You can share the presentation with me in the group. In the meanwhile, we can have 8 presentation first.
Okay.
Okay, so A8 will be by Dr. Kamal Yadav, and he'll be presenting from Kalinga Institute of Medical Science. Do we have the presenter here? Yes. Doctor, you can start your presentation.
Good afternoon, everyone. I'm presenting.
Please go to slides, show mode and present.
The one at the bottom.
Showing, sir?
No, you have not put it on slideshow mode. Please put it on slideshow mode.
You can also go to the top row. There is a slideshow tab over there next to animations. You can click that on the top. Yes. From beginning. From beginning. Yeah, you can start now.
Good afternoon, everyone. I'm presenting a case report on pyloric atresia in neonate. Our experience with rare anomalies from KIMS, Bhubaneswar. Pyloric atresia, a rare congenital condition, estimated incidence 1 in 1 lakh live births, which is account for less than 1% of the all intestine atresias. It can be presented isolated or can be associated with other anomalies like epidermolysis bullosa or any other intestine atresias, which further complicates its management. It can be complete or partial obstruction at level of gastric pylorus. Main symptoms will be non-bilious vomiting, feeding intolerance, and upper abdomen distension in neonatal periods. Case report: a 3-day-old female preterm baby with low birth weight born via LSCS due to ruptured PRM was brought to casualty with history of copious non-bilious vomiting, intolerance of feed, and upper abdomen distension since birth. On examination, baby had a distended upper abdomen with visible gastric peristalsis. Nasogastric tube was inserted for gastric decompression and only gastric content aspirated, no bilious aspiration was done. For confirm the diagnosis, we have done the X-ray abdomen and pelvis, which revealed a large gastric bowel with complete absence of distal gastric bowel gas. So, and other all investigations for preoperative and biomarkers were done, and patient planned for exploratory laparotomy. Right upper quadrant transverse incision was made, and on exploration, usually distended stomach with hard and prominent pylorus was found, and other small intestine from duodenum and jejunum up to IC junction was evaluated for any other anomalies or any atresias, which were normal. No other anomalies were found. So pyloric atresic membrane were identified. This is the thickened pylorus, and this is the mucosectomy. Pyloric web was dissected, and continuation of the mucosation was done. And here is inchimiculis pyeloplasty was done, while transanastomotic umbilical vein catheter was placed, and then on POD3 patient one X-ray was done and is showing the gas passing the distally to the stomach, and in follow-up about 6 weeks dye study was done, and dye, as we can see, the dye passing smoothly distal to the stomach in a small intestine. Now the discussion part: pyloric atresia can be part of hereditary multiple intestinal atresias involving the stomach, duodenum, jejunum, colon, and rectum. It is an extreme rare occurrence with possibility of being associated with combined immunodeficiency syndrome. Pyloric atresia must be considered in different diagnosis of high intestinal obstruction in newborn with bile-free emesis. Plain X-ray and UGI endoscopy contrast study can be done to confirm the diagnosis. Surgical treatment is an emergency and should not be held and the presumption of a poor outcome. So our conclusion is the importance of early recognition using simple radiological investigations and appropriate management of pyloric atresia depend on its type to ensure normal feeding and good post-operative outcome in neonates. Thank you.
He finished on time.
Yes. Any questions?
Dr. Kamal, a quick question.
Yes.
Already a case had been presented by one of your colleagues in the previous presentation. So tell me quickly, in this scenario, you had definitely a good outcome, but do you have a subset of patients where the outcome may not be that good with pyloric atresia? You have that in the presentation, but you probably need to answer this here. A subset of patients with pyloric atresia who will have a stomy course or not so favorable outcome.
Yes, sir. Mostly in type 3 patients with there is gap is there. Then we do gastrogesinostomy. There will be like delayed gastric emptying and other complications, leakage and everything. We can poor outcome will be there. Or patient with a delayed presentation with electrolyte imbalance.
Yes. And also probably those with epidermolysis bullosa. Can you tell me any specific points which will be differently managed by you if the child has epidermolysis bullosa?
So then we evaluate for any family history, like previously first one child has first male child. Is there any history of it?
The
Or no?
child will have loss of fluid,
Yes, sir.
temperature imbalances.
Temperature
What is
and yes, sir.
Karmis syndrome? What is Karmis syndrome? Before I ask Dr. Krishna to ask questions, Dr. Abhirami. No, never mind, Dr.
Mention, you have
Kamal.
mentioned, yeah.
Yeah.
So there's a question in the chat box. Anything was done intra-op to rule out intestinal atresia?
Yes, ma'am. We tried to negotiate the tube distally to rule out any duodenal atresia or anything. But
Okay. So the syndrome is already mentioned, except that you need to know the components. You have mentioned the components in the presentation.
okay.
Yeah. Okay.
Thank you.
So if any questions from Dr. Krishna, sir? You're on mute, sir. Okay. So
The dice study which was done post-operatively, which was
Yes,
showing
sir.
like everything is draining on the left side. So
Yeah,
what
yeah.
intraoperative procedure was there? Then I just missed it.
So intraoperatively, we have done the just mucosectomy and pyeloplasty.
Okay, just show the post-op dice study which was done after 1 month.
Yes,
I
sir.
heard.
This one, sir.
Okay. That actually duodenum is not crossing on the right side. It is somewhat looking like a malrotation for me. That's why I felt like that. Okay.
So Dr. Asha, are you ready with the presentation?
Yes,
A very
yes,
good
ma'am.
presentation. Yeah.
I'm
Okay.
ready.
A good
Before
presentation,
Dr.
Dr.
Asha, you present, just I missed it. Did Dr. Kamal present within time?
Yes, sir. Yes, sir.
Yeah,
Okay,
yeah,
okay,
yeah.
fine.
Yeah,
Please,
he did.
Dr. Asha.
Thank you, sir.
Thank you. Over to you, Dr. Asha. Can we see your slide?
Yes, ma'am. I think it should be visible. Is it visible?
No, no.
I
not
think
yet.
Dr.
I
Kamal,
think the
you have to
previous
stop
speaker
sharing that.
needs to. Yeah.
Is it visible, ma'am?
Not it.
I thought I was sharing it.
Yeah, Vidya, please share it again.
Yeah, sharing it again.
Yes.
Is it visible?
Yes.
Yes, ma'am. Yeah, thank you. Good afternoon, everyone. I'm Dr. Asha. Today, I'm presenting the case report with the title, A Case of Intermittent Bilious Emesis in a Term Neonate. This was reported from IMS and some hospital, Bhubaneswar. Ma'am, next slide, please. Well, we are much aware that intestinal obstruction is a common surgical cause of an NICU admissions. Often in these cases, we get some history like maternal polyhydramnios, or the infant may present with bilious emesis, and sometimes there could be failure to pass meconium, and rarely we may get abdominal distension also. But the issue is whenever we do an abdominal X-ray in these infants, we may not get a very typical gas pattern in this, and often this abdominal X-ray remain inconclusive. So here we have had this case where the neonate presented with intermittent bilious emesis without any other cardinal signs of intestinal obstruction. So our case was like this. Next slide, please. Next slide, please. Hello?
Yeah, Vidya, you need to click on the arrow there. Yeah.
Yeah. We had a 39-weeker infant who had an uneventful antenatal history, born by LSCS, with a birth weight of 2.7 kg, who cried at birth and there was no issues. So baby was shifted to mother side immediately, and baby was nursed well at the mother side with a DBF. Around 6 hours of life, the baby has started multiple episodes of bilious vomiting. So we immediately shifted the baby to NICU and we examined. The examination was fairly normal. So we suspected some GI obstruction. So our next DD was certainly sepsis also. So we started empirical antibiotics and kept the baby NPO. Following which we got the abdominal x-rays. We were not able to conclude much with the abdominal x-rays. We got some paucity of the colonic and rectal gas. But however, we can see in this x-ray, there was no specific gas pattern. We got the abdomen Dopplers also, which were normal. By day 3, child slowly stabilized. Then we restarted the feast thinking it could have been some transient issue. Next slide, please. However, after we restarted the feeds around day 3, the infant again started to have bilious vomiting by around day 6. So that's when we thought we would have to repeat an abdominal X-ray, but unfortunately that was normal again. Then we went for a CCT where we found the web at the duodenal jejunal flexure. I think if you are able to see my cursor where we can see this is the distended duodenum, and here we are probably having the DU web. So by day 10, we decided to discuss with the pediatric surgeon, and the child underwent the exploratory laparotomy also. Intraoperatively, we found a transitional zone at the DJ junction. In the next image, we can see the intraop picture. The jejunum is there and the dilated duodenum is there. So then we did a resection of the DJ anastomosis, following which baby was shifted to NICU, NJ was placed, TPN was initiated. Feeds were restarted by around day 7, day post-op 7. And eventually feeds were increased and baby was tolerating feeds well, and baby started receiving DBF around day 14 only. And we immediately discharged the baby also. Next slide, please. So mainly what we are trying to say is GI webs are not very usual in the neonates. However, it is more commonly seen in the second part of duodenum. Webs at the DJ flexure are always surgically challenging. Next slide, please. So we conclude that congenital duodenal web is a rare cause of small intestinal obstruction in neonates, and intermittent bilious emesis is an important clinical manifestation and should help in suspecting any underlying problem. CET may be of significant help in such cases. Other investigations may remain inconclusive. So this was a rare presentation of a web without typical symptoms. Thank you.
Well, presentation.
Keep present.
Before doing the CT, one upper GI contrast would have helped and given more information, right?
Sir, certainly, sir. Certainly, we wanted to do an upper GI contrast, but the child had so much of emesis continuously, and we had one case in our past where there was a small issue with the aspiration of this contrast following which. So we discussed with the pediatric surgeon and the radiologist also. So we withheld the upper GI contrast and went for CCT directly.
Without oral contrast, only.
Yes, sir. Because of the fear of emesis and emesis-induced chemical pneumonitis. Baby had recurrent emesis.
Okay. Dr. Asha, you mentioned about abdomen Doppler. What is the reason to get the abdomen Doppler?
Ma'am, we were suspecting if there was any malrotation in the child. So, and before going on to any bigger investigation, certainly we wanted to rule it out at that point of time. So, we got one abdomen ultrasound Doppler and scans.
So, what will be the finding in malrotation in Doppler?
There will be the superior mesenteric artery and the superior mesenteric vein will be malpositioned.
Whirlpool thing, yeah. Good. Okay. Any more questions?
Yeah. So there was a chat comment regarding the web versus membrane. So in which category of the classification, if you have gone through the classification of atresia, if you would, so where will you fit this particular case into? Because the type 1 would have a cord, not a membrane, if you have seen, isn't it? The second one varies, and then type 3 and so on.
Actually, sir, some researchers do believe web is a subpart of atresia itself. Some researchers believe a web is a different entity per se. Some researchers do classify it around stage 3 type of an issue where there could be some amount of web could be a part of an atresia.
Thank you.
Thank you, sir.
So, due to the
Does she
time
finish on
constraint,
time? Does this the Asha completing on time?
Yes, she was on time.
so we'll be moving to the next presentation.
Thank
so
you.
Thank you, Doctor. So Dr. Jaya Sai Monica will be presenting from Dr. Ambedkar Medical College. Over to you, Dr. Jaya.
Is my screen sharing visible?
Yes.
Everyone?
Yeah.
Yeah, am I audible?
Yeah, you're audible.
Can I'm ready
Please
with
start.
that. Can I start?
Yeah, please start.
Okay, this is Jaisai Monica. I'm presenting a case from case of choledochal cyst with chronic pancreatitis at LMI and drainage. Choledochal cyst with chronic pancreatitis may share the same etiology that is along common channel. However, very rarely we find the simultaneous occurrence of the choledochal cyst with the chronic pancreatitis requiring the surgical drainage. Roux and Y gingival loop is a standard drainage limb for both the pancreatic duct as well as the common hepatic duct. In Whipple's procedure, using a Roux and Y limb gingival loop is a standard operative procedure for malignancy. Similarly, for the colorectal cyst, hepatico-jejunal stomy to a Roux-en-Y jejunal limb is the standard procedure. However, when both the chronic pancreatitis as well as the colorectal cyst occur within the same patient, there is a dilemma as to whether the pancreatic duct as well as the common hepatic duct can be drained into the same Roux-en-Y loop. Drainage into the same Roux-en-Y loop is a standard reconstruction after the Whipple's procedure, which is associated with significant mortality and morbidity, which is attributed to the anastomotic leak, that is 10 to 30%. Here, in this child, we are describing an 8-year-old female child with the chronic pancreatitis with choledochal cyst. She had type 1 choledochal cyst with one episode of cholangitis with pancreatic duct dilated above 7 millimeters with multiple calculi. In this patient, we have done 13 centimeter long lateral pancreatico-jejunal stomy using a Roux-en-Y loop. Instead of anastomosing the common hepatic duct to the same jejunal loop, we mobilized the duodenum and performed the hepatico-duodenal stomy after the excision of the choledochal cyst. Postoperatively, the child recovered well with minimum bile leak for 2 days, and after follow-up of 2 months, the child is asymptomatic. When it's coming to the discussion, hepatico-jejunal duodenal stomy has been, after the choledochal cyst excision, has been used for the pediatric surgeons, especially after the laparoscopic choledochal cyst excision. This anastomosis delivers the bile into the duodenum, hence it is being more physiological and is also accessible for the ERCP in the future. In spite of all these advantages, this is not the standard procedure for bile duct drainage because of the risk of the bile gastric reflux and long-term risk of the gastric malignancy. When both the ducts are anastomosed to the same Roux-en-Y loop in Whipple surgery, the increased risk of the anastomotic leak is attributed to the soft pancreas. However, anastomosis is stronger in a fibrosed pancreas in chronic pancreatitis, but the lateral pancreatico-jejunal stomy may increase the chances of the anastomotic leak. Hence, we decided to drain the two ducts separately, with pancreas being drained by the Roux limb and the bile duct draining into the duodenum. So, discussion: there's a paucity of literature on drainage procedures when both the chronic pancreatitis as well as the choledochal cyst occur simultaneously. Though we decided to drain the two ducts separately, there is no literature to prove or negate its any advantages. There have been 7 cases reported so far. There is enough evidence to prove that draining both the ducts into the same jejunal limb when the Whipple's leads to the anastomotic leak and mortality rate up to 25%. Recent evidence suggests that in Whipple's procedure, anastomosing the pancreas to the stomach instead of the jejunum leads to far lower risk of the anastomotic leak. Hence, we chose to drain the two ducts separately into the duodenum and jejunum respectively. Child requires long-term follow-up and evaluation for bile gastritis. In case hepatico-duodenostomy has to be dismantled in the future, in case of bile gastritis or cholangitis, in that case, the bile duct can be anastomosed to the same Roux-en-Y limb, which is located close to the porta. Thank you.
Yeah, she finished on time.
Yeah.
Good case. It's very rare to see choledochal cyst and chronic pancreatitis.
Yes, sir.
About the chronic pancreatitis, was it chronic calcific pancreatitis with the duct dilatation and interluminal calculi or something like that?
Yes,
You
sir.
didn't give any information about the chronic pancreatitis part.
It was a chronic calcified pancreatic duct, and it was dilated about 7 millimeters, and it had multiple calculi, sir.
Okay, that's what the most common indication to do a lateral pancreatitis.
Yes, sir.
The dilated duct and interluminal calculi.
Yes, sir.
If there's no question, can we move to the next presentation?
Yeah.
Okay, so the last presentation for this session will be by Dr. Suman Upin from STM College of Medical Science. Do we have the presenter here? Yes. Dr. Suman, you can start your presentation. Are you here? Is the presenter here?
Yeah, I can see the presentation.
Hello. Am I audible, ma'am?
Yes, you are audible. You can start your
I'm Dr.
presentation.
Suman. I'm Dr. Suman from Pediatrics of SDM Medical College, Dharwad. And my moderator is Prashant sir from Pediatric Surgery Department. I am having a case series on unusual presentation of obstruction in the pediatric field. Intestinal obstruction is a common condition in the pediatrics, often presenting with recurrent episodes of vomiting, abdominal distension, and pain. The underlying cause can be either acquired or it could be congenital. And they can start occurring from right from the neonatal period through the adulthood. Despite we're having advancement in the tools like USG, CT, contrast study, still identifying the exact cause of the obstruction sometimes remains challenging. However, surgical intervention should not be delayed in order to prevent the serious complications. And in older children compared to the neonates, symptoms tends to be non-specific. And imaging is essential for accurately determining the origin, location, and extent of the obstruction. And this study explores the rare and unusual etiologies in the pediatric intestinal obstruction. It was a retrospective study which was done with 11 pediatric patients who underwent surgery for the acute intestinal obstruction between 2022 to 2024. And each case had presented with an uncommon underlying cause. Coming to my first case, it was a case of a 45-day-old female male baby who was presented with a 4-day history of abdominal distension and the bilious vomiting. And an examination revealed a distended abdomen with a visible bowel loops and a palpable mass in the subhepatic region. And on a USC done shown a feature suggestive of small bowel obstruction with a cystic mass in the right subhepatic region, measuring about 4 into 4 centimeter. And also during the child underwent exploratory laparotomy, and during surgery, we noted that a 3 mesenteric cyst arising from the terminal ileum was found, causing obstruction. The cyst and the affected bowel were resected, and the histopathology confirmed the mesenteric lymphangioma. Mesenteric lymphangioma, with the prevalence being less than 1%, it was a very rare cause causing the subacute intestinal obstruction. Coming to the second case, it was an acute bowel obstruction secondary to the inflammatory band with internal herniation through the mesenteric defect. It was a 4-year-old kid who presented with a 3-day sudden onset of abdominal pain, bilious vomiting, and abdominal distension. The child was having tachypnea, tachycardia, and with generalized abdominal distension with guarding and rigidity. And there were absent bowel sounds which suggested a severe acute bowel obstruction. And on intra findings, we noted that there was a fluid found cavity, and if you can see, there was an inflammatory band which was constricting the ileum, and a mesenteric defect about 80 centimeter from the duodenal noted, allowing herniation of the terminal ileum, and was also causing the twist and obstruction at the level of the jejunum. So the inflammatory band was resected, and followed by which the jejunum, which was having a twist, was been the ileum loop got released, and end-to-end anastomosis was been done. It was a congenital diaphragmatic hernia with a gastric volvulus. It was a 1-year-old kid presented with vomiting and rapid breathing for 1 day without any history of fever or a foreign body ingestion. And examination revealed tachypnea, tachycardia with hypoxia, that is room air saturation was 91% with subpostal retraction, indicating respiratory distress. Chest X-ray done shown a mediastinal shift to the right and the compression of the left lung by the herniated abdominal content, stomach. And CT scan confirmed a grossly distended stomach displaced into the left hemithorax, suggesting acute gastric volvulus, and with a mediastinal shift with a left lung collapse. And on an intra finding, surgery revealed a 4 centimeter defect, that is posterior lateral diaphragmatic defect with herniation of the stomach, and small intestine and the spleen, and the defect was been repaired, and the anterior gastropexy was been performed. Next case was the distal ileal obstruction from a vitelline intestinal cyst. It was a term baby born to primary gravida mother by vaginal delivery, which was initially admitted in ICU for the supervised feeding due to the Doppler abnormalities. And the child reached full feeds by the day 3 and was being shifted to the mother's side. But the very next day, on the day 4, the child had 3 episodes of bilious vomiting, and a positive septic strain was also been noted. So, attributing to the sepsis, the child was being kept NPO, IV fluids were started, and antibiotics were started. But upon reintroducing the feeds after 48 hours later, the baby again continued to have the bilious vomiting and abdominal distension. And imaging revealed a dilated bowel loop and a dye study shown a micropulla. And the child underwent an exploratory laparotomy on the day 7 and found a distal ileal obstruction caused by vitellointestinal cyst compressing the ileal wall. The cyst along with the ileum was been resected, and end-to-end anastomosis was been done, and histopathology confirmed the diagnosis, and the child was been kept NPO for the next 5 days, and the feeds were started on the day 5, and the child tolerated the feeds well and was discharged on the day 21 of life. Coming to the next case, it was a jejunal intussusception presenting a 5-year-old child who presented with a 1-day history of abdominal pain, distension, and a vomiting. Examination revealed tachycardia and a palpable mass in the paraumbilical region with absent bowel sounds. And we noted that there was multiple air fluid levels noted on abdominal X-ray, and on the intra findings, a 10 centimeter jejunal interception was located, which was 100 centimeter from the ileocecal junction. And trial of a manual reduction was been given, but it was unsuccessful, requiring resection and end-to-end anastomosis. But also noted that there was a small segment of terminal ileum intussusception, which was also been identified and was reduced manually successfully. Coming to another case, that is a pyloric verb in a patient with a Down syndrome. It was a 1-year-old boy with a Down syndrome who presented with a 5-day history of non-bilious vomiting, fever, and a rapid breath and reduced urine output. That very and a poor weight gain. The surprising case was the child had similar complaints, that is of non-bilious vomiting requiring 10 previous hospital admission, and the child was been attributed to some GR and was being given prokinetic, but the child continued to have the vomiting intermittently, and the child also failed to thrive. On examination, the child was taken tachypneic with subcostal and intercostal retractions, and crepitations were heard. And ABG got them shown hypochloremic, comatobolic with hyponatremia and hypokalemia, indicating pyloric stenosis. An abdominal X-ray revealed a dilated stomach, and ultrasound suggested that there is some obstruction at the level of the pylorus, and followed by which upper GI contrast confirmed that pylorus. Intraoperatively, we noted that there is a pyloric valve with, which was been excised, and henchimicularis anastomosis was been performed. Coming to the 7th case, that is ileoileal knotting,
Dr. Suman,
which is a rare presentation.
Dr. Suman, you'll have to conclude because you've already shot 6 minute 30.
Yes, sir. Yes, sir. 2 more cases, sir.
You have to
13-year-old
quickly
boy.
wrap it up.
13-year-old boy came to the emergency room with a severe abdominal pain, bilious vomiting, and obstruction with a history of 1 day. And the child was having cardiac rigidity and absent bowel sounds. X-ray showed and confirmed that there was a feature suggestive of intestinal obstruction. And child had laparotomy, which revealed the ileoileal knotting, that is about 10 to 15 centimeter from the ileal junction, and the knotted section was resected and end-to-end anastomosis was been done. This was a case of ileocholic interception ileal tumor, that is a pathological lead point, where the child was a 13-year-old presented with history of abdominal pain and a bilious vomiting with stable vital signs and with abdominal tenderness and abdominal distension. Ileocecal interception with respect to neoplastic terminal ileum mass was confined to the bowel. The child underwent right hemicolectomy, and the child, they also subjected the tissue for the immunohistochemistry, confirmed the for 79A, CD45, CD10, and CD20 positive, and it was a feature suggestive of a Burkitt's lymphoma. Next, it was a case of bowel mucormycosis, which was noted in the post-COVID time. The earlier-old girl who had got diabetes as a sequel of the post-COVID, and she presented the history of abdominal pain and distension. She was having unstable vitals. She was presented in shock and showed a severely distended abdomen and tender abdomen with high blood sugars. And first, initially, she was being medically resuscitated and was taken to explorated laparotomy, which revealed over 10 ileal perforation and fecal contamination. Approximately 15 centimeter of the inflamed bowel was resected and stoma was created. And histopathology confirmed there was invasive mucormycosis, and the child was treated with IV amphotericin 4 weeks closure. Post-operatively, her blood sugars were controlled, and she continued the amphotericin for 6 weeks and was discharged in good condition.
Doctor, this is going on for long. We are already 20 minutes late for the next session.
Okay, ma'am.
So can we very interesting cases, but unfortunately because of the time limit, we have to move to the next session. So if we have any questions, can we have it in the chat box, sir? Or you wanted to have some question, Doctor?
I think we can skip the Q&A.
Yes. Oh, thank you, Dr. Suman. Moving on to the next session.
We can have any questions if there are any. We can have it in the chat box.
Yes. So next session is on thoracic surgery. We have Dr. Vidya, Dr. Rajesh Srivastava, and Dr. Sandeep as chairpersons. Over to you.
And just a reminder for the participants that we'll be having the award ceremony at around 4 p.m. So please stay tuned till then. The names of the winners would be announced at around 4 p.m. And thank you, Dr. Abhirami, Dr. Krishna, and Anjan sir for chairing the session. It was a great session.
We will have our own conference call, and then we'll decide. And
yeah. Thank you, sir. Thank you. Over to you.
Thank you.
So thank you, Dr. Tanmay, for keeping up the time. From here on, I'll take over checking the time.
Thank you, Dr. Abhirami.
Thank you.
We'll now start the second session, which will be focused on thoracic pediatric surgery. I would like to introduce my co-chairpersons, Dr. Rajesh Srivastava and Dr. Sandeep Kiskusa. I hope both of you have joined. So are you there?
Yeah, I am here.
Sure.
Maybe.
So we'll begin the session. The first presenter, can you please share your screen, Dr. Hemalata Malya?
Yeah, I'm sharing my screen.
Yeah.
Okay, am I audible?
You're clearly audible.
Yeah. So I'm just sharing my screen now.
The
So is
screen
it
is visible. Could you please put it on slideshow mode?
Yeah, I have put it on slideshow mode.
May begin.
So good afternoon, everyone. So today I'm presenting a rare case of iatrogenic esophageal perforation in an extremely low birth weight neonate, which was managed under the guidance of pediatric surgeon Dr. Anil Kumar and neonatologist Dr. Prashant Kumar, Dr. Sujit Kaya, Dr. Ishwar Reddy, and Dr. Sandeep from Cloud9 Hospital, HRBR. So coming to the case, this was a male newborn, one of the twins, weighing around 760 grams, born at 26 plus 4 weeks gestation by an emergency section in view of preterm premature rupture of membranes. The baby cried immediately and the baby was shifted to further supportive care, which baby received surfactant for RDS and baby was on antibiotics for probable sepsis. Luckily, there was no feed intolerance, there was no PDA, and the baby reached full OGT feeds by around day 5 of life. Suddenly on day 16, by day 16, the baby was still on mechanical ventilator, but on minimal oxygen support, and the baby was on full OGT feeds and antibiotics. But on day 16, suddenly the baby's respiratory distress started worsening with increased oxygen requirement. And we need to upgrade the baby's respiratory support to high frequency oscillatory ventilation from conventional ventilator. So any worsening of respiratory distress, we immediately do a chest x-ray. So we have also done that, but chest x-ray was showing a coiling of OGT tube. So just prior to this incident, just prior to the worsening of respiratory distress, there was a history of the duty pediatric doctor trying to do multiple attempts of OGT tube insertion with great difficulty. But prior to all that, the baby was on full OGT feeds, which is a point to be noted. Once the X-ray was done, it was showing an coiling of OGT tube with a perforation of the esophagus. Immediately, the pediatric surgeon was informed, and we did a dye study, which was showing right-sided pleural filling of the dye. Since there was a pleural effusion, an intercostal tube drainage was done and secured. And following the next day, we did a feeding jejunostomy also because it was a preterm baby, very extremely low birth weight. We need to take care of the nutrition. So that's why we did a feeding jejunostomy. Gradually, the baby's respiratory distress got better and the baby was weaned off respiratory support. 13 days after the perforation, we did a repeat radiological dye study to make sure that the perforation is healing. The dye study showed the perforation has healed and there is no leak. On day 18 of the perforation, an OG tube was inserted under CM guidance, and the baby was started on OGT feeds, gradually increased, which the baby tolerated well, and direct oral feeds were started once the baby was around 1.56 kg, around day 71 of life. And the baby went home successfully on day 84 with a weight of 1.8 kgs at around a gestation of 38 weeks. So coming to the discussion, traumatic perforation of the pharyngoesophageal junction is first reported by Elkoff et al. Since then, there has been increasing incidence of esophageal perforation, especially in SDA babies or premature babies. The reported incidence is 0.8% in preterm infants, but it can reach up to 4% in babies whose weight is less than 750 grams. The most important risk factors for perforation is vigorous suctioning of nasopharynx or oropharynx and repeated attempts of putting nasogastric tube or endotracheal intubation. Spontaneous rupture has also been mentioned, especially in cases where there is a history of birth asphyxia or where there is esophagitis. In our case, the perforation happened because there was a repeated attempts of putting the OG tube. So most of the time, the presenting symptoms will be worsening respiratory distress. Sometimes it can present with bloody oral secretions, inability to pass gastric tube, fever, cyanosis or subcutaneous emphysema. And diagnosis can usually be made clinically, but also chest X-ray and a dye study will also help. Chest X-ray usually will show pneumothorax or pneumomediastinum or subcutaneous air. If it's a proximal esophageal perforation, usually it presents with left-sided anomalies. If it's a distal esophageal perforation, usually it's present with right-sided anomalies. And the contrast will help more in identifying the issue. So usual management is usually it can be a surgical management or a conservative management. Conservative management usually helps in most of the cases. The conservative management will be with broad spectrum antibiotics, taking care of the nutrition, and the gastrostomy feeds for 7 to 10 days. Surgical intervention does not usually improve the survival, and it should be restricted to patients with severe complications only. And there is no reported difference in the survival of those treated medically and surgically. In our case, probably we did a feeding jejunostomy because the baby was very extremely premature newborn with an extremely low birth weight, and we did a feeding jejunostomy rather than gastrostomy because gastrostomy again can cause reflux, which can again impair with the healing of the esophageal perforation. So these are my references. Thank you. So takeaway home messages, we should, with increasing incidence of more extremely low birth weight and extreme premature babies, we should be very careful in doing every procedure. Esophageal perforation should be one of the diagnoses when there is any worsening respiratory distress, and most of the cases we can manage conservatively rather than going for surgical treatment. Thank you.
Thank you, Thank you, Dr. Hemlata. That was very good presentation. Sir, do you have any questions, Sandeep sir?
Yeah, thank you, Hemlata. Very well managed, very complex case. I have a few questions. Firstly, who did the contrast study?
So the pediatric surgeon, sir, Dr. Anil.
Okay, because there's a lot of contrast in that. I think your suspicion itself, there is a leak, and there. If you see can you just show your picture? Yeah. Because I think you don't have to have so much contrast. That's a lot, massive amount of contrast. Yeah. I would say that if you're looking for a leak, you just need a little contrast to see that there's a leak, and that's enough. That's my first comment on that. Mm-hmm. Secondly, this baby is a very small baby. Yeah. You mentioned you did a feeding jejunostomy on this child. Yeah. And there are many medical therapies, and I believe this child had TPN also, correct?
TPN also, yes, sir. But luckily we could reach to full OGT fits by around day 5 days.
Yeah. So the question is why on day 13 you were back on feeds, which is so you could have given TPN for another 2 weeks and avoided a surgery for this child.
Yeah.
My question.
Yeah. So
in most places, this baby is a very, very small baby. Yeah. Doing a feeding jejunostomy on a 750 grammer is not an easy operation. Yes, it's a very difficult operation. The simplest thing would have been to give TPN for this child, and 2 weeks, less than 2 weeks, in TPN you would have been sorted out. So any answer for that?
I think we were a little struggling getting the lines, peripheral lines for the PN. I mean, PIC line also we have to insert for such a small baby. Getting peripheral lines was little difficult, so we have to go for PIC line also, which was little difficult for this child. So that was the reason mainly. We have to keep on well with the nutrition also. So that was the decision after discussion we made between the pediatrician, neonatologist, and the pediatric surgeons. Getting peripheral line for TPN was little difficult.
Okay. Any other questions? I think in the chat box there is some question regarding what size, in your case, and what size of tube was used, feeding tube. And is there any literature on that?
Sorry, I didn't get the question.
What size of feeding tube was used, orogastric tube?
We tried, when the initial incident happened, we tried with 6 size orogastric tube.
That would be appropriate. That's what. Is there any literature based on size and type of tube?
This is a question. Which can cause the perforation. I'm not aware. Sorry.
And what are the classical X-ray findings? Your apart from coiling, the initial X-ray had very subtle findings in your case, with just I think right pleural effusion. What are some of the classical X-ray findings of esophageal perforation?
It can present as pneumothorax, pneumomediastinum, or subcutaneous emphysema. So these are any proximal esophageal perforation usually presents with left-sided anomalies. That's what they say, and distal esophageal perforation usually presents with right-sided anomalies. Yeah.
If there are no more questions, can we move ahead to the next presentation? Thank you, Doctor.
Yeah, thank you.
I now request Dr. Rushikesh to share the screen. Is it visible? Could you please put it in slideshow mode and start your presentation? Dr. Rushikesh, you may start your presentation.
Yes, ma'am. Am I audible?
Yes, you're audible now.
Oh, yeah. So I'll be presenting the case of thoracic miscap from the GMCH Aurangabad. So we have a case of a mother who was presented with a G2P1 mother, which was a non-consanguineous marriage with spontaneous conception and non-significant family history. The significant history was only the ANC scan of 24 period of gestation was suggestive of polyhydramnios and left-sided congenital diaphragmatic hernia. So the rest of the course of her ANC period was uneventful. So at birth, it was a full-term LSS delivery in view of previous LSS. Baby cried immediately after birth, as it was a birth weight of 2.1 kg. It was a small for gestation age baby. Post birth, there was history of decreased there was on examination decreased hearing on the left side and tachypnea. As per the ANC scans, were suggest of left sided CDH. Bowel sounds were also heard in the left side of the thoracic region. Another the contrasting feature was there was unable to pass NG tube beyond the mark of 10 centimeter. Otherwise, there were no any other dysmorphic features, neither any other congenital anomalies also. So this was the X-ray, which was a post birth. As the first arrow, it is suggestive of abruptly ending feeding tube at around 10 centimeter, and we can clearly see the bowel loops were also present in the left thoracic region. So we did the investigation as per the USG abdominal suggestive of the small bowels present in the left chest, which was suggestive of the left-sided CDH. And also we did 2D echo after almost 2.5 hours of life, which was suggestive of pulmonary persistent hypertension. So, and USG score was normal, and rest of the genetic workup which was counseled but could not be done. So we had a case with query suggestive of esophageal atresia with tracheostomy fistula and left-sided CDH. So we had done pre-op resuscitation. So baby was intubated electively in view of antenatal scans of CDH in the delivery room only. But post intubation there was present tachycardia, saturations were fluctuating, shock was also there. So baby was started with IV fluids, anatropes, TPN, antibiotics, and was intubated and was on mechanical ventilation. So this was a case which was diagnosed with CDH and we along with TAPE. So baby was initially stabilized. Later on, baby was planned for operative procedure as the PPHN part was also resolving. So post stabilization, we did the corrective surgery, which was suggested with the CDH repair with ICD with left hemithorax, followed by we did gastrostomy attached to underwater still, followed by GE junction ligation. And there was also, because of the large contents, it was prosthetic patch abdominoplasty. And for the TAPE part, we did left cervical esophagostomy. Post, of course, baby parents were counseled for genetic workup but could not be done. Also, baby developed PPHN on day post of day 1, which tried to be managed medically, which we also do high frequency ventilation. For PPHN, we required multiple inotropic settings, and because of the severe refractory cardiogenic shock, baby could not be revived beyond the post of day 4. So we had a stormy course for the post of day 3. So these are some of the surgical images. As we can see in the image 1, these are the stomach and the bowel loops were also present in the CDH part, along with the second image is suggestive of the primary defect repair, and this is for the cervical esophagostomy. And we can see clearly in the X-ray that the CDH part has been also resolved, but the X-ray was started developing pneumonia-like presentation. So these were some of the surgical findings, but still we were facing some of the challenges such as whether the diagnosis of TAPE was also accurate, because there will be still diagnostic dilemma. And also for the if post diagnosis is emergency gastrostomy only safe, we are also dealing with the problems of air leaks into the GIT, and also whether how to go, whether the all to go repairs in one stage or the multiple staging, and also the availability of ECMO was also a serious question. But as per we did all the primary repair in the single setting, but there have been some different surgical approaches, such as the gastroesophageal division is that it is an extensive procedure. Also, the simple ligation of the distal esophagus can be done, but it can be complicated by the stricture on lateral side. Also, can be bending at the done at the same time using elastic silicone rubber tubing. And the other approach can be TAPE ligation with esophageal repair via right thoracotomy, along with extracorporeal placement of the abdominal contents. Or the other approaches can be prosthetic patch placement for the diaphragmatic repair, or the simple prosthetic patch abdominoplasty can be done. So these are some of the different approaches which have been documented, but there is no clear-cut indication or the demarcation for which and when to go which surgeries. So I would like to emphasize on the take-home message that it will be a less reportedly cases, and there have been no specific protocols clearly defined for the TAPE with CDH. But treatment has to be individualized, and regarding the considering the severity of pulmonary PPHN, CDH, or the presence or absence of any other fistula, along with the rest of the GC of the patient, and also the availability of services such as HFO, INO, or the ECMO part also. So these are all the things or queries which had to be sought before operating such cases. So these are some of my references from which we have gone through, and later on followed to go with the single stage repair along with the contents of the abdominal contents with patch repair. So these were all the slides that I have prepared for the presentation.
Thank
He
you, Dr.
overshot the
Rishikesh.
time.
Sorry, he was within time?
He was
Overshot.
within time. No, he was within time.
Okay. Thank you for the presentation of a
Yes,
very rare and complex case.
Yes, ma'am.
Sir, do you have any questions, Dr. Ajay or Dr. Sandeep?
Rishikesh,
Yes,
very
sir.
well presented. And on what day of life the operation was performed?
Sir, baby's OT was performed on day 2, almost at least 30 hours of life, sir.
Okay, and was the baby hemodynamically stable at that time?
Yes, sir. After managing the PPHN, as it was initially mild PPHN, and it was medically responding, so later only baby was planned for operative procedure.
Sandeep, sir?
Rishikesh, lots of things to learn, lots of things for us to, reflect on. So when the baby was, after you had finished your diaphragmatic repair, was the child stable? Was the child on any inotropes?
Actually, sir, pre-op only we had started with dobutamine inotropic support, as it was PPHN and sildenafil also. So we continued throughout the surgery, but later on post-op, sir, we needed to escalate the inotropes, sir. Otherwise, baby was on dobutamine, sildenafil only.
So I would presume that you're on low dose of dobutamine, correct? Dobutamine
Yes, sir. Yes,
is
sir.
fine.
Yes, sir. It was on low dose. Yes, sir.
And when you finished the repair, the diaphragmatic repair, how was the child? Because you
sir,
did the diaphragmatic repair first, correct?
Yes, sir. There was one desaturation event during the procedure, but post repair, sir, baby was fine till almost 2 hours post-op. Later on, baby started crashing and deteriorating, sir.
No. Immediate after you finish your diaphragmatic repair,
Yes,
the
sir.
child was
Baby was
well?
stable, sir. No, sir. Baby was stable immediately, sir.
So you decided to continue the operation.
Yes, sir.
Okay. And just remind me,
yes, sir.
You did a gastrostomy and then you ligated the G junction?
Yes, sir. Because, sir, the event of desaturation, when was it was there? It was actually the air leak, sir, through the GI compartment, and there was a low lung volumes on the ventilatory setting, suggest a flow tidal volume. So initially we had gone for.
Yes. So after you finished the ligation, could you have just stopped there rather than continue on for the esophagostomy?
Yes, sir. Post ligation, we did cervical esophagostomy to prevent further.
No. What I mean was, you had problems at that point, right? When you're done the ligation, the child was now becoming unstable. So should you have just stopped there rather than go? The esophagostomy takes time. It will take another hour. Or more than an hour, if not.
Yes, sir. Yes, sir. The event which was desaturation, it was a brief event, sir, lasting for 15 to 20 seconds. But post that there wasn't any mishap during the surgery. So that's when we planned for further continuation of the surgery, sir.
Okay.
Yes, sir.
Yeah. So I think it is a very complex case, and
Yes,
these
sir.
are all very, very difficult to make guidelines for the entire gamut of all the anomalies that we will see along with TEF and CDF.
Yes, sir.
But I think the main principle of surgery would be always to remain safe. And
yes, sir. Yes, sir.
In these, sometimes the less we do, the better for the child. And often we should not hesitate to be always err on being very safe with the child, not continuing to do the entire operation. If necessary, even just a very quick ligation of the fistula. That's all. You don't have to reconstruct. You don't have to do a gastrostomy. You don't have to do esophagostomy. Just like you do the CDH repair, open the chest, ligate the fistula, come out.
Yes.
If you ligate the fistula, just one ligation over the fistula, it sorts out the problem. Then you can ventilate. Your problem is ventilation, correct?
Yes, sir.
So that is the thing. I've seen, I know a lot of surgeons who would persist in doing the major big operation, extraperitoneal repair, extrapleural dissection, and I think we will lose the child after that. So lots of things to learn and reflect. Thank you for this. Thank you for bringing this case. Even though it's not a good outcome, there's so much to learn from it. Thank you.
Yes, sir. Yes, thank you, sir.
Thank you, Dr. Rishikesh. We'll move on to the next presentation, sir. Dr. Karpagavalli.
Yes, ma'am.
Please share your presentation. Are you having any difficulty sharing the presentation?
Yes, ma'am. I'm not able to share the presentation.
You can share the presentation in the group. We can have B4 present first, and then we can have you.
We'll move to Dr. Shweta. Are you ready, Dr. Shweta?
Yes, ma'am.
Yeah, please share your screen.
Is the screen visible?
Not yet.
2 minutes. Is the screen now visible?
Yes, now visible.
So, good afternoon to all of you. This is Dr. Shweta.
The presentation is not shown. Just your folder with the presentation is shown. Can you open your presentation and put it on slideshow?
2 minutes.
When you click on share, you have to share entire screen. Yeah.
Is it being shared? Is it visible?
Yes, yes, visible now. Please start.
Good afternoon to all of you. This is Dr. Shweta. I will be going to present my study of tracheocephalic fistula in units, which is an observational study from Tertiary Care Hospital from HGPGI Lucknow. So, as we all know, TEF is an abnormal connection between the esophagus and trachea, which was first described in 17th century. It represents one of the most commonly and challenging congenital anomalies with incidence of 1:3,500 live births. It can be associated with anomalies of other systems also. As a neonatologist, our perspective is early diagnosis, identification of the anomalies associated, stabilization, and pre and post-operative care related to the patients. So the aim and objectives of the study was to identify clinical profile and outcomes of neonates with TEF in a tertiary care hospital. The methodology was, it was a retrospective observational study which was done at tertiary care NICU of HGPGI and Department of Pediatrics Surgery, Lucknow, with a study duration of 9 years, that was from July 2015 to June 2024. The subjects were inborn and outborn units admitted to NICU of pediatric surgery or in the NICU itself. In the methodology, we collected data from HIS, which is our hospital information system, and medical files, and total neonates with TEF were identified. We saw their baseline characteristics, associations, treatment, complications, and final outcomes. The statistical analysis was done by descriptive statistics for continuous variable, along with which categorical data was summarized as proportional percentage. SPSS 26 was used for data analysis. In the results, we have total of 51 patients which were of the TEF. In the baseline characteristics, the mean gestational age was 37 weeks with interquartile age of 26.15 to 28. The median birth weight was 2,500 grams with interquartile age of 2 kg to 2.645 kg. Majority of the patients, that is 94.1% of the patients, were outborn and majority were of male. Out of the total, 64.7% of the babies were delivered by LSCS, and there is a history of polyhydramnios in 23.5% of the total babies. We look at the associated anomalies which were associated with such patients and found that 23.5% of the patients had genitourinary abnormalities associated with them, while 21.5% had cardiac abnormalities. Factal association was seen in 13.8% of the babies, while musculoskeletal abnormalities were seen in 9.8% of the babies. 7.8% of the babies had GI abnormalities with them. Among all of them, type C TEF was most common, which constitute 92.1% of the total patients, followed by type A and type H, with 2 patients in each group. If we see at the complications, then leak was present in 25.4% of the population, stricture in 27.5%, and pneumonia in 74.5% of the total patients. We were able to successfully discharge 72.6% of the patients, which was 37. 6 patients went left against medical advice during their treatment, while 15.7% succumbed to the TEF. So in a conclusion, TEF is one of the most important differential of surgical respiratory distress syndrome in units. It can be diagnosed by X-ray, but we have to rule out other anomalies also. And treatment is always surgical, but pre and post-operative care is of utmost important. Thank you.
Thank you, Dr. Shweta. Was he within time?
Yeah.
He's within time.
Thank you. As a pediatrician, I think it is important to, you've had majority of your patients as outborn patients.
Yes, ma'am.
Yeah, in your case, so what is the importance of transport care?
Ma'am, the transport care is important because the patients of a take, there is continuous fogging from the mouth, and so it's very necessary that the proper suctioning or position should be done, and the patients are brought in a proper care, at least not so that we can, at least pneumonia part can be managed beforehand.
Dr. Swetha, what other GI abnormalities did you encounter in TEF patients?
Sir, in the case of TEF patients, we encountered duodenal atresia in some cases, along with which annular pancreas, and 2 patients were also having extrahepatic biliary atresia associated with them.
Any anorectal malformation?
Yes, sir. There was anal atresia in many patients. Then there was a cloaca, undifferentiated cloaca, and other disorder associated with the anal atresia, like anal stenosis, were also present.
Okay, and you have mentioned about the stricture also. After how much time, it's like, did you encounter a stricture in follow-up or during the hospital stay only?
Sir, generally we encounter stricture in follow-up. Generally, initially the babies are able to suck the milk, but in the follow-up, when we start complementary feeding, then on starting somewhat solid feed, it is seen that they are not able to swallow the feed or are having regurgitation. Then we suspect it can present. Yes.
So how long was your follow-up period?
Sir, we followed up to about 1 year the patients.
Sandeep sir?
Yeah, Shweta, very nice presentation, long duration of your study. Your leak rate was about 25%, which means 1 in 4 patients were leaking.
Yes,
did you look at whether there were minor leaks, major leaks? Did you have to reoperate?
Sir, majority of the leak were of minor in nature, and reoperation was not required. Only there were 3 patients of the total who developed mediastinitis, for which we reoperated the patients.
Okay, so this even 25%. Do you know what the literature is? Rate is about the leaks. How frequently leaks are present?
Sir,
I know it's very varied, but 25% looks a little too much on the higher side. Have you looked at it, reassessed, and seen there's some techniques that you need to improve on? I know this. Are these done by residents or by? Do you have a consultant supervising you?
Sir, we have consultants who supervise us. It is done by pediatric surgery team, sir.
So have you looked at whether the gap was large or any reasons why your leak rate is around 25%?
Sir, मतलब
तेरा जब हो जाएगा फिर मैं वापस थोड़ी देर के लिए ऑफ कर दूंगी.
There are patients who are having long gap also, but exact reason, sir, that I can see now.
Certainly, there's something that you can look at when you have data like this. You're looking back,
yes.
At least, or even stated that you don't have that data, but it's something that we need to look at. 25% is a big number. 1 in 4 patients are leaking.
Yes.
Sir, can we go to the next presentation? We are running short of time. Yeah.
We'll move to the next session.
Yes.
The screen is visible. Dr. Karpagavali, please start.
Good afternoon, ma'am and sir. I'm Dr. Karpagavali from Department of Pediatrics from Sri Ramachandra University, and pediatric surgeon is Dr. Madhu, sir. Next slide, please. Introduction is about foreign body aspiration is airway obstruction more commonly seen in children when compared to adults due to the anatomical variation of the airway. Subglottic airway is small, hence there will be a marked resistance in the airflow in case of edema and foreign body aspiration. It is usually asymptomatic, often found accidental. Obstruction can lead to difficulties with ventilation, oxygenation, resulting in significant mortality and morbidity. And identification and timely intervention to remove foreign body is important in management of foreign body aspiration. It is most commonly seen in children less than 5 years of age. Here is a 5-year-old boy presented with cough and mild wheeze. While eliciting a history, mother gave a history of probable foreign body aspiration. A foreign body LED bulb was situated in the right segmental bronchus, is confirmed with CT scan, which was contrast, and removal of foreign body was attempted in outside hospital. Since it was deep-seated, procedure was unsuccessful. Hence, advised to do thoracotomy for the removal of foreign body. Anxious parents fearing open surgery came to the SRMC. In SRMC, foreign body was removed with rigid bronchoscopy with the team efforts of anesthetists, pediatric surgeons, and intensivists. Multiple attempts were required as the foreign body was deep and stuck to the mucosa, and it was difficult to not to break also, as in the risk for bleeding. And the child did not require any post-op ventilation and was discharged in good condition with oral antibiotics. Here it was deep-seated inside the foreign body. In the foreign body, this was the LED bulb. Next slide. And bronchoscopy-wise thoracotomy and foreign body aspiration is commonly finding in children that should be diagnosed based on the clinical signs and radiological studies, so that the timely diagnosis and successful removal of foreign body is essential to reduce the complications and mortality. Gold standard for bronchoscopy is the gold standard for foreign body removal. Rigid bronchoscopy is used for foreign body removal compared to flexible bronchoscopy because of the following reasons: ability to ventilate, better visualization with a rigid telescope, and a greater versatility with the various size of forceps. In this case, we have been used with optic forceps. Next slide. Bronchoscopy is the best diagnostic and therapeutic modality that may fail in case of impaction, peripheral foreign body, or technical difficulties. When bronchoscopy fails, the removal of foreign body in bronchus via thoracotomy, bronchotomy is required in less than 2% of the cases. Potential complications of rigid bronchoscopy include bronchospasms, desaturation, bleeding, airway edema, in addition to the inherent risk of anesthesia. Beyond the understanding of the diagnosis and the management of the foreign body, there should be a strong need and push for the awareness, education, prevention among the caregivers, healthcare providers, and manufacturers of food and toys. Thank you for the opportunity.
Thank you, doctor. That was a nice presentation. So do we have any questions?
Thank you, Karpavalli, for that nice presentation. I believe you used an optical forceps, correct?
Yes, sir.
Yeah. So this child had the foreign body wedged in a segmental bronchus.
Yeah, sir. Right segmental bronchus.
Which segment?
Terminal segments.
Which terminal segment? You know there are
So
segments. Which segment? Upper lobe, middle lobe, lower lobe. There are lobes there.
Right lower lobe, sir.
Right lower lobe. And was it impacted? Just impacted? Was there rupture of the? Was it?
There was no rupture, sir. It was just impacted. Child was also initial presentation. Child was not having any other symptoms as such. Had occasional coughs. With the history only, we were able to elicit.
So how many days was it impacted?
3 weeks, sir.
3 weeks. Okay. So after removing it, were you concerned about any narrowing or any problems with that?
No,
because
sir.
it's been wedged for 3 weeks. There can be some ischemic injury there.
It was the no ischemic injury, but it was edematous and it was.
Yeah. So have you followed up that child?
Yes, sir. He had been coming for the referee after 2 weeks. No other complaints from their side, sir. And we didn't repeat any CT. Repeat CT was not done.
Repeat X-ray?
Initially was X-ray was done, which was not showing any finding as such.
So if that area strictures, what would you expect on an X-ray?
So
if that area strictures, what would you expect on the X-ray?
I'm not sure.
Since we're running short on time, Dr. Karpagavalli, you can answer on the chat box, okay, if
Yes,
possible. And there are some other questions in the chat box which you can take. So shall we move on to the next one? I'll request Dr. Jaikrit to share his presentation. Dr. Jakrath Patil, are you there? Yeah, it's visible. Please put it on slideshow mode.
Hello, am I audible, ma'am?
Yes, you're audible. Please start.
Good evening. My name is Dr. Jaykrit. I'm be presenting a paper on oxygen index as a predictor of mortality in congenital diaphragmatic hernia, retrospective single center analysis. I'll be doing this presentation under the guidance of Dr. Madhu. My primary aim would be to evaluate the predictive accuracy of oxygenation index in determining survival outcomes in neonates with congenital diaphragmatic hernia. And we also sought to establish the best OA cutoff for predicting survival, assessing its sensitivity, specificity in identifying neonates at risk of mortality. And ultimately, my aim was to provide evidence on utility of oxygenation index as a key marker in guiding clinical decision, including timing of surgical intervention. This is my PICOT statement, where I collected data from 2004 to 2024, and I used oxygenation index as a postnatal predictor. And I compared this with other modalities like LHR ratios. And my primary outcome was on survival rates, and secondary was predictive accuracy of OA and need for advanced respiratory interventions. Totally, I was able to collect data of 66 neonates, out of which 61 were eligible for participation. One was excluded due to congenital anomalies, and another 4 went AMA. Out of which you can see that majority of them were under the conventional group. And from 2004 to 2024, we had only one death post-op, which was a 1.16 kg neonate who succumbed on day 45 of post-op due to necrotizing enterocolitis. And most of the deaths have occurred in HFOV or the mixed ventilation group, which correlates due to the severity of the pulmonary hypertension as well as the pulmonary hypoplasia. These are the baseline characteristics of my neonates. In this, statistically significant data is that of requirement of inotropes, which showed a significant p-value of less than 0.01, where we can see 92% of the deaths which occurred required inotropes, followed by requirement of INO, where almost 100% of the babies who died required INO, and severity of pulmonary hypertension. Other significant data in this is one is gestational age and birth weight, which had a statistical significance of less than 0.05, but rest all other data were not statistically significant. Moving on to the main, that is the oxygenation index. You can see that almost 90% of the survivors who had a lower oxygenation index of less than 15 survived with the odds ratio of 52, which indicates that 52 times they were likely to survive in a low OI threshold compared to that of a high OI threshold. And when I adjusted it for an adjusted odd ratio by eliminating confounding factors like gestational age, birth weight, etc., it was still 36 times the units with lower OI survive compared to those of higher OI. And pulmonary hypertension also was statistically significant, but compared to the oxygenation index, it had a lower significance. Almost 22 neonates of OI less than 7.5 survived, whereas 10 neonates with OI more than 45 succumbed. When I put this on a ROC curve, the best OI cutoff which I found was 17, which had a sensitivity value of 89% and specificity of 90%, which again, this 17 value discriminates how my OI or lower OI babies have a better survivability compared to higher OI babies. Median OI, which I found in survivors was 6, whereas in non-survivors was 50. Now, comparing this with other modalities which we commonly use, the most common use is the lung-head ratio, or the other thing is the observed to expected lung-head ratio. This has a 79% of sensitivity and 73% of specificity, but the problem is it doesn't have, it is a prenatal done diagnosis, and it doesn't give a real-time evaluation of the baby post-op, post-delivery. Whereas the one which has come closer to my study is the Wilford Hall and Santa Rosa prediction, which has 83% sensitivity and 87% specificity. But the problem with this is that it only takes into PaO2 and PCO2 values, but it doesn't take into account what is the ventilation strategies which have been employed for that disease. The other is the CDSH's staging system, total fetal to lung volume ratio, and pulmonary hypertension. But of all the modalities, oxygen index still stands out to be better. And now latest what is coming up is, instead of depending on oxygen index, now clinicians are more depending on oxygen saturation index, where instead of using a PaO2, we rely on the saturation of the pre-rectal saturation of the neonate. By this, we avoid repeated blood gases analysis. So concluding over the 20-year-old period, the survival rates of the CDH.
Doctor, you have overshoot your time.
Okay. These are my references. Any questions?
Thank you. That was a very nice presentation. Questions. What do you think is the role of ECMO and what is the cutoff you used for OI cutoff you used for ECMO?
Ma'am, normally for INO we use OI cutoff 20, ma'am. For ECMO more than 40.
But in your center, you've what are the modalities that you've used?
Ma'am, we have used HFOV and inhaled nitric oxide, ma'am.
Is there any other questions?
No, we are already running late. We should move to
Yeah.
next presentation.
We'll move on. These presenters were from the pediatrics team. Next 4 presenters will be from the general surgery team. Dr. Nemi Chandra, are you ready with your presentation?
Yes, sir. Am I audible, ma'am?
Yes, you're audible.
Good afternoon to one and all. I am Dr. Nemi Chandra from Safdarjung Hospital, Delhi. I'll be presenting a case. We had a 13-year-old boy who presented to our emergency with pain abdomen since the last three days, with bilious vomiting, abdominal distension, and non-passes of stool and flatus. He had no history of diarrhea, weight loss, or trauma.
Could you pause for a moment, please? I'm not able to see the slides. Yes, now it's visible. Yeah, you can continue. Please put it on slideshow and mode and continue.
Will I restart, ma'am? Hello?
Yes, go ahead. Yes.
Is it visible, ma'am?
Yes, visible.
Okay, I'm starting. We had a 13-year-old male who presented to us with pain abdomen, abdominal distension, bilious vomiting, and non-passive stool and flatus for the past 3 days. Patient had no no history of diarrhea, weight loss, or trauma. He was a known case of Down syndrome and congenital diaphragmatic hernia who was on a regular follow-up at AIMS Delhi since birth. But the patient was long follow-up for the past 7 years. This is on examination. We found that the patient was having tachycardia, hypotension. Patient had a respiratory rate of 18 beats per minute regular, but no obvious respiratory distress. On head-to-toe examination, patient had features of Down syndrome such as fat facial features, flat nasal bridge, semian crease in the palm, and so on. On per abdomen examination, we could see abdominal distension, generalized tenderness, guarding with sluggish bowel sounds, suggestive of peritonitis. Whereas a chest examination revealed equal air entry in the bilateral upper lung fields. Bowel sounds were heard in the bilateral lower lung fields, since the patient was congenital diaphragmatic hernia. This is a chest X-ray showing that on the right side, the first one you can see that the patient had dilated bowel loops in the abdomen. On the right, on the second, you can see that the bowel was herniating into the chest. This is a CT of this patient showing a defect of approximately 5 cross 4 centimeter in this diaphragm centrally with small bowel loop herniating. But the CT showed that the bowel loops were having normal enhancement with no features of bowel ischemia. But now we were in a dilemma because patient had features of peritonitis clinically, but radiologically patient the bowel seemed normal enhancement. So we trusted our clinical judgment and went ahead with preparing up the patient for an expedited laparotomy. So we resuscitated the patient, took the patient up for expedited laparotomy, where we found that there was a 5 centimeter length of ileal loop which was herniating through a small defect in the falciform ligament as shown in the diagram. And this segment was found to be gangrenous. So we had to resect this gangrenous segment and we did an ileo-ileal side-to-side stapler anastomosis. The first video here shows you that there was a 5 centimeter length of gangrenous bowel segment, which was approximately 15 centimeter from the ileocecal junction, which was gangrenous, which was resected and anastomosed. Whereas the second video will show you that since the patient was a known case of congenital diaphragmatic hernia, this is the retrosternal hernia. That's a bilateral Morgagnis hernia. So, but since you can see the defect is very wide enough, the bowel which herniated through the diaphragm was healthy, but the actual problem was the bowel which has herniated to the falciform defect. So going with the next one, we just repaired the diaphragmatic defect with PDS1 suture. Post-operatively, patient had an ICU stay for 2 days, extubated on day 1 and discharged on day 7. This is a post-op X-ray comparing the pre-op and post-op X-ray. The second X-ray shows you that the expanded lung fields. So on discussion, patient intraperitoneal or post-operative, very common in adults. So they can either present as bowel obstruction, rarely strangulation and peritonitis. These are few of the case reports which are. So take home message will be internal hernias can present as acute abdomen. High clinical index of suspicion is needed. CCT is helpful but less sensitive. Diagnostic laparoscopy is the need of the hour. Timely surgical intervention and can decrease both morbidity and mortality. Thank you.
Thank you, Dr. Nemichanda. That was an
The time
interesting.
has been kept up.
Yeah, thank you. Thank you, Dr. Abhiranga. Any questions? Dr. Ajay, Sandeep, sir?
Thank you, Dr. Nimi. Very nice case, very interesting. Did you make a diagnosis of the bilateral Morgagni hernia pre-operatively?
The patient was a known case of diaphragmatic hernia, sir. He was on regular follow-up at team study, but last 7 years he was lost to follow. So we knew it. But since we got a CT done and the CT showed us that there was a diaphragmatic hernia, but the bowel was having normal vascularity. So we were in a dilemma.
No. Did you diagnose it pre-operative? Because it's clearly visible on the X-ray. You can see the bowel loops in the center, not
Yes,
on the
sir. Yes, sir.
laterally.
We did.
And on the CT, and on CT also you would have made a diagnosis. Was it made or not made?
Yes, sir. It was made pre-operatively, sir.
So you were going in knowing that there was a Morgagni hernia, bilateral Morgagni.
Yes, sir. We did know that that it was a Morgagni hernia, sir.
One question. One question, Dr. Nemi. The patient was already having peritonitis. So
Yes.
you are already emphasizing that the bowel vascularity was maintained. It was showing on CT. So why CT was done?
Sir,
if the patient
actually,
was
the patient had features of peritonitis, and we were resuscitate the patient, and since it was an acute abdomen case, and she was already known case of congenital diaphragmatic hernia of 13-year-old age. So we went ahead, got the CT because the patient was awaiting for a laparotomy. So we had time, so we got the CT, sir. But peritonitis per se, we should have taken up the patient immediately. So we thought that the CT would give us extra information, so we got the CT. But peritonitis as such, we should have taken up the patient immediately.
Thank you. We'll move on to the next presenter now. Dr. Somashekar Reddy. Are you there? Yeah. The presentation is visible. You can start your presentation.
One second. Good afternoon, everyone. Am I audible?
Yes, you're audible. Please put in slideshow.
Good afternoon, everyone. And my name is Dr. Somashekar. I am about to present the paper of early versus late VATS in epimathoracis of pediatric age group. And epimathoracis is nothing but collection of purulent material in pleural space. With epimathoracis incidence is about 10 out of 1 lakh people population with a significant morbidity and mortality. In maximum incidence is seen between the age group of 1 to 4 years and broadly classified into 3 phases. Initially, the exudative phase due to inflammatory cascade and followed by fibropurulent phase due to coagulation cascade and followed by organizing phase due to fibroblast chemotaxis. And mainly basic underlying management is due to treat the underlying infection with IV antibiotics followed by debridement and decortication of the thick endopleura and allow the lung to expand. And if it not treated in appropriate time with complications like pleural fibrosis, calcifications, bronchogenic fistula, and empyema necessities will complications. My main objectives are how patient present like a clinical profile of the children in early and late VATS and duration of ventilator support and post-op ICU stay and ICD institute and hospital stay in early and late VATS. It is a retrospective observation study done at St. Martha's Hospital between January 2007 to December 2023.
Sorry to interrupt, but your slides are not moving. We're not able to see your slides. Can you please put it in slideshow mode?
Yeah, it's already in slideshow. Sorry.
You have to go into slideshow. Yeah. Go into slideshow. You have to I have shared a video. You have to make it visible for everyone. The video there. I think you have not.
Now it is visible.
No, it isn't.
Could you at least move to the appropriate slide that you're presenting? Click on the appropriate slide.
Not sure. They are not visible.
We are able to see the slides, so you can keep the slide which is you are presenting now.
Yeah, this is the slide. Why?
The result slide is now being shown.
Yeah, now objective slides is going on.
Doctor, we're able to see the result slide. Could you please go to the objective slide?
So slide 3 is objective slide, so you can go up actually.
Sorry.
We're able to see the introduction slide now. Okay, please reshare. If you need some more time, we'll move on to the next presenter.
Sorry.
Okay, yeah, better now. Please continue.
Now we can see. Sorry?
Yes, now you're on the introduction slide.
Introductions. Okay.
Somashekar, I have shared the presentation for you. You can refer to this one and present.
Share.
I have shared it.
It's
okay.
shared. Please look at that and present.
Hello.
Thank you. Starting up. Empymathoracis is nothing but collection of purulent fluid in pleural cavity. It has an incidence rate of around 10 in 1 lakh people population with a significant morbidity and mortality rate. And the maximum incidence is seen in between age group of 1 to 4 years old, and broadly classified into 3 phases like an exudative phase, fibropurulent phase, organized phase. Exudative phase due to inflammatory cascade, and fibropurulent phase is due to this coagulation cascade, and which leads to down regulation of the fibropurulent phase, and results in deposition of fibrin, and followed by organizing phase, and which leads to fibroblast chemotaxis. And the mainstay of treatment is to treat the underlying infection, like an stating with IV antibiotics, followed by debridement and decortication of thickened pleura, and allow the lung to expand. If it is not treated at an appropriate time, it leads to the complications like fibrosis and thickening of the pleura, and calcification, and bronchopleural fistula formation, and empyema necessitates. Next slide, please. My main objectives are to look for the clinical profile of children who presented in early and in late phase of period, and duration of ventilator support, and post of ICU stay and ICD institute hospital stay who presented in early and late. It is a retrospective observational study done at St. Martha's Hospital between 2017 to 2023. All patients who underwent VATS for empymathoracis of pediatric age group in St. Martha's Hospital included in this study. All the children are divided into 2 groups based on interval between onset of symptoms and the time of operation, which is less than 2 weeks, Group A, and more than 2 weeks, Group B. Next slide, please. And we can see the slides like now. Here we can see thickened pleura, and here we can see bronchopleural fistula. In middle, we can see fibropurulent and with septations and loculation. Here down left, it CT scan showing bronchopleural fistula. Next slide, please. And my total sample size is 24, and among boys are 14 and girls are 10. And coming to laterality, right side empymathoracis are 15 in number, and left side empymathoracis are 9 in number. Children who underwent early intervention with the use of ventilator support, and post-op ICU stay, ICD duration, post-op hospital stay is comparatively less when compared to late VATS, and with a significant p-value. Next slide, please. In clinical presentation, there is no significant difference between presentation apart from the severity, how they presented. On imaging, few of the children who presented late have CT thorax showing necrotizing parenchyma. Apart that, all the children showing that loculations and septations. Mean pH and sugar of pleural fluid is significantly low who presented late, and most of the blood cultures and pleural fluid cultures are negative as already treated with enough IV antibiotics, and mortality among all children is 0. Two cases who presented late initially underwent VATS and decortication, which has significant lung involvement. Which not improved clinically, we taken up to open thoracotomy. All cases who underwent VATS followed up with chest X-ray shows optimal lung expansion, no reinsertion of ICD, and patients who presented early and CT suggestive of only purulent collection and multilocular septations have technically it is very easy to operate and decreased ICU hospital stay and decreased mortality. In same way, who presented late and with thickened pleura, it is a little difficult to operate and increased hospital stay and ICU stay with a significant morbidity and mortality rate. Next slide, please. I want to conclude that early who underwent
The
early
time
intervention
exceeded. Time has been
better.
exceeded. Yes. Yeah.
Sorry, better post-op surgical improvement and short duration of post-op ICU stay, ICD in-situ hospital stay. Who presented late, possibility of tubercular empyema as a differential. The patient who presented two of the cases had needed of a repeat procedure. Thank you.
Thank you, Dr. Somshekar. Is there any questions? Okay, we'll move on to the next presenter. Dr. Kirtika, are you ready?
Yes, ma'am.
Please share your screen.
Is it visible, ma'am?
Yes, it's visible.
Yes. Good afternoon, respected faculty. I'm Kritika, second year general surgery postgraduate from Ramchandra Medical College in Chennai, and I'm doing this presentation under the guidance of the head of the Department of Pediatric Surgery, Professor Madhu. So coming to the case, a 3-year-old male child came to us of fever with cough for 3 days, and they also gave a history of recurrent URA. On examining, the child was stable, and taking a closer look at the respiratory system, the child was found to have a dull note at the left inframammary, infraaxillary, and infrascapular regions on percussion. Chest X-ray was done, which showed soft tissue opacity at the left hemithorax. So we proceeded to do an ultrasound thorax, which showed a loculated left-sided pleural effusion with hyperechoic foci within. On further evaluation, a HRCT thorax was done, which showed a massive left-sided pleural effusion with septations within and collapse of the underlying lung. This is where our pediatric surgery teams were called in, and the child was then planned for VATS with decortication. These were our intraoperative findings. To our surprise, we were seeing a large cystic lesion, and there were no evidence of any fluid or pus within. And here in this image, you can see how closely this cystic lesion is associated with the heart and the ribs here. So due to this intraoperative finding, the first differential which came to our mind was CCAM, and we abandoned the procedure as the parents were not counseled regarding need for lobectomy, and we had not arranged for any post-operative ventilatory care. So we deferred further procedure, and the child was discharged with oral antibiotics. The child then came back to us after 2 weeks. At this point, we did a repeat HRCT thorax. This showed a large 10 cross 5.2 cross 5 centimeter lesion, which volume of almost 130 cc, arising from the pleura in the left hemithorax. You can see in the CT images here. So on discussing with the radiologists, they diagnosed this to be a pleuropulmonary blastoma. Owing to the malignant nature of this condition, the child was planned for an excision. So these were our intraoperative findings. So initially, we aspirated fluid from within the cyst in order to decompress it to aid for easy dissection. The cystic swelling is carefully dissected from the surrounding structures. Here we can see the associations with the heart, lung, and the pleura here. Intraoperatively, this lesion was thought to be a pleuropericardial cyst. Here, again, taking care to preserve the phrenic nerve, this cyst was very carefully dissected and excised in toto and sent for histopathological examination. So, post-operatively, the child recovered good. Cytology came back, which was negative for malignant cells. And when biopsy did come back, it was reported as a benign cyst, which was probably a hamartomas lesion or a cystic lymphangioma. So coming to the discussion, our understanding of pleuropulmonary blastoma is not sufficient and it is quite easy to be misdiagnosed, such as in our case. I would like to conclude by saying these two things. There's always more to than what meets the eye. Accurate imaging helps determine the right treatment plan. A stitch in time saves 9. Early diagnosis and prompt treatment of congenital lung lesions offer the possibility of normal lung development for these children. Thank you.
Thank you, Dr. Kirtika. I think she was on time.
Yeah, she was on time.
Is there any questions?
Thank you, Dr. Kirtika. This is a very nice presentation. So this looked like a lymphatic malformation of the of a pericardia pleural cyst, pleura.
Yes, sir. Intraoperatively, it was found to be arising from the pleura, sir. It was closely
Okay,
adherent.
so the massive pleural effusion was a rupture of it into the pleural cavity. What do you think? What do you think was the presentation initially?
Sir, we rather thought it was misdiagnosed in the imaging, sir. There was no signs of any fluid into the pleural cavity. As we saw in the first VAPS image, it was a isolated cystic lesion and there were no any signs of any fluid in the pleural cavity, sir.
Yeah. So you said massive pleural effusion, but if you look at your X-ray, it doesn't look like massive pleural effusion.
Yes, sir. X-ray revealed a soft tissue opacity, but on the ultrasound and CT, it was reported as pleural effusion, sir.
So because if you look at the X-ray, it doesn't look like massive pleural effusion. It just looks like
Yes,
loculated to one area. So
both on the ultrasound and the CT, this was what told us it could be a pleural effusion, sir, rather than a soft tissue lesion. So based on this, we had planned for a decortication procedure.
interesting case.
If there are no more questions, we'll proceed to our last presenter, Dr. Animesh. Are you there?
Hello, can you hear me?
Yes, you're audible. Please share your screen.
Yeah.
It is visible. Please start with your presentation in slideshow mode.
Yeah. So, good afternoon, everyone. I'm Dr. Nimish. I'm a third-year surgical resident in the Department of Surgery, Netaji Subhash Chandra Bose Medical College, Jabalpur. So, I'm here to share my experience on the short duration of posting I had in Pediatric Surgery Department, which revised my perspective towards objectivity from subjectivity. And this particularly happened while managing a case of empyema-thoracis. So, empyema-thoracis refers to the infection of the fluid in the pleural space, which has the most common cause in children is parapneumonic effusion, and the aim of the treatment is to re-expand the compressed lung and treatment of the parenchymal infection. We have different treatment options available like intercostal drainage tube insertion, VATS, and open decortication. So what I used to see in general surgery ward posting was the patient was initially managed with intercostal drainage tube, looked for the response, and if the patient doesn't respond, we would proceed with the open decortication. And what I observed in the pediatric surgery department was the patient had the predetermined treatment plan based on the image system. And that is when I got introduced to the Jabalpur image-based system, staging system for stage-directed therapy, which is a more objective system than the American Thoracic Society system based on the duration of the empyema-thoracis. So this is the JIBSS stage-directed therapy, which is based on the ultrasonographic imaging finding and the CT imaging finding, and provides us a guide for the different treatment strategies available. And this particularly helped to decrease the mean hospital stays, decrease reintervention rates, and decrease the conversion rates of the procedures. So EBM has that the evidence-based medicine has its own value and individualized treatment plans and provides guidelines for stratifying severity. It has reduced morbidity and mortality in the patients. It has shortened hospital stay, reduced need for reintervention. It has increased the cost effectiveness and the standardization of care and helps in the early diagnosis. So why there is so much focus on the evidence-based medicine? That is, it is a more objective approach and has optimized resource utilization and to avoid unnecessary and harmful practice. It has increased standardization of care. It has increased the transparency and accountability by gaining the patient trust, and it has encouraged ongoing research, fostering culture of continuous learning and adaptation. So it has included the clinical expertise, best evidence, and the patient values. So what I think that the general surgical resident should be a general surgical resident should be posted in the specialty posting so that they had exposure to a particular and get the broader outlook of a particular disease where they follow a objective treatment protocol. And so as a general surgical resident, if you're posted in a remote setting or a hospital where a specialty posting is not, specialty treatment is not there, you can always recognize the disease earlier and refer the patient earlier to better the treatment outcome of the patient. So these are some stills from the pediatric surgery OT, and I'm extremely grateful and lucky to have published a paper on idiopathic chylopericardium managed with a thoracoscopic window pericardiotomy as a first author. Thank you.
Time managed well within the time.
Thank you. Thank you, Dr. Animesh.
Thank you.
This was our last presentation. So do you have any questions? Dr. Ajay, any questions?
What was the objective of the presentation? Was it Jabalpur image-based staging or your change perspective?
My change perspective towards an objectivity, sir. So that is when I got introduced to the Jabalpur image-based system, that is when my perspective changed about the different protocol and how the evidence-based medicine has changed over time.
So the protocols are also for general surgery also, no? Not only for super specialties.
Yes, sir. So, but we aren't exposed to these protocols like particular cases in general surgery, like in pediatric department, we are exposed to these empyema thoracis more. So we get to know about the treatment strategies more, and we can inculcate in our life.
What are some other options after ICD insertion apart from VATS and decortication? Any other?
We can use fibrinolysis with ICD insertion, but actually it was not used in our setting because of cost restraints.
Okay. I guess any other questions, sir? Okay. With this, I think we can end this session. I think there are no questions in the chat box as well. So thank you, Dr. Animesh. And I would like to thank Sandeep sir and Dr. Ajay for taking out your valuable time to chair the session today. Thank you, sir.
Thank you.
We can move to the next session. Dr. Tanmay, over to you.
Thank you so much, Vidya, for chairing this session along with the other chairpersons. So for the next session, we have a session on pediatric urology, which will be co-chaired by Dr. Arun and Dr. Prabhu. I hope they are there with us. Dr. Prabhu.
Yeah.
Great. Can you turn on your... Yeah. So we can start with the first presentation. It is by Aditya Sharma. Please share your presentation, Aditya. He's from BHU. Yeah, your screen is visible. Please switch it on to slideshow mode and start the presentation.
Good evening, sir. Sir, am I audible?
Yeah, you are audible. Yeah.
Good evening, respected jury members. I'm Aditya Sharma. Today I will be presenting an unusual presentation of upper ureteric obstruction due to tubercular lymph nodes and its successful management using appendicular conduit. So I will be presenting under the supervision of my faculty members, Dr. Ruchira Nandan, Professor Vaibhav Pandey, and Professor Ajay Narayan Gangopadhyay, sir. So a 7-year girl with pain in the right side of the upper abdomen presented to the general surgery, and she was later referred and managed in the pediatric surgery. On clinical examination, there were no significant findings like palpable lump, but the complaints persisted for more than 6 months. So she was subjected to certain sets of investigations. First was the USG whole abdomen, where upper ureteric encasement with the lymph nodal mass was seen. Thereafter, she was subjected to CT, which showed that right upper ureteric encasement with lymph nodal mass with right side upper hydroureteronecrosis was seen. So a diagnostic lab was planned and a lymph node caseating mass was identified encasing and obstructing the upper end of the ureter. DJ stenting was attempted, but it failed. Primary stichoplasty was not done in view of risk of the urinary fistula formation, as the clinical picture mimicked tuberculosis. She was followed up, but same symptoms developed after 6 weeks. So the patient was planned for subsequent stichoplasty and excision of the ureteric stricture. But until that time, during the diagnostic lab, the tissue was sent for the histopathological examination, which turned out to be the tubercular lymph node. So ATT was started. So these are the pictures of the definitive surgery, where in the first picture we can see that the colonic mobilization is being done. And in the second picture, we can see that lymph node mass encasing the right upper ureter is seen. And in the third picture, we can see the strictured segment at the right upper ureter. In the second slide, in the first picture, we can see that the strictured segment being spatulated. And in the second picture, we can see that the appendix base is being clamped and cut with attached arterial supply and being mobilized. And in the third picture, we can see that ureter and appendix are anastomosed with the and along with that, digestant is placed. So the first one is the pre-op CT urography picture, which is showing the dye is not passing in the right ureter due to obstruction stricture at the upper end of the right ureter. And this image is the post-op CT urography done after 2 years. Patient was followed for 2 years, which is showing the dye is passing the right ureter to the bladder. So the take-home message, as we can see in this video, that the primary anastomosis of the ureteric stricture due to the tuberculosis should not be done in the first go, because there are very high chances of the formation of the urinary fistula. And as in seen in our case, appendix can be used as conduit when ureteric length is short for anastomosis. In the video shown, we can clearly see that the dye is passing from the strictured portion after the appendicular conduit has been plain till the bladder. And until the 2 years of the follow-up, patient has not reported any complaint, nor UTI or any other complication arising out of surgery. Thank you, sir.
Thank you for your presentation, Aditya.
Yeah, within the time, please within time.
Thank you very much. Any questions, Arun sir or Prabhu sir?
Yeah. Was there any other primary source that was able to identify, just X-ray or anything?
Yes, sir. It was done, but it was, sir, unremarkable. There was no primary foci for tuberculosis or any other.
Child was thriving well?
6-year-old female.
The child was thriving well, the weight and height.
Yes, sir. She was she was doing well, and she was well hydrated, and she was built also was very good. That is why, sir, she was
very nicely managed case.
Yes, sir.
My another last question is, what you would have done if it would have been on the left side?
Yes, sir. Sir, there are a number of options. Like first, we can it will depend on the length of the stricture, location of the stricture, and the renal function. If renal function is not there, it's poor, then there is no point in managing that stricture. So after assessing all this, we have number of options. Like we can try to cannulate and insert the DJ stand. If that is not possible, then we can use argon lasers. We can proceed laparoscopically.
No, just tell me what are the alternatives for the ureteric substitutes for the left side of the ureter. Right side you can use appendix.
Yes, sir. Yes, sir.
That's a easy one. What if the appendectomy has been done on the right side itself?
Yes, sir. Sir, we would have proceed with we would have anastomose ureter with the other ureter. We can anastomose that, or we could have used ileal conduit. We could, if required, or if we could have
it's called
Sir,
It's called as?
with ileum, sir.
Yeah.
Sir, it's a diversion, sir. We would have done diversion.
That's Monty procedure. Yes, sir. Okay.
And
Thank you.
yes, sir. Thank you.
Dr.
I have
Prabhu,
no questions, sir. Yeah, please go ahead. Please go ahead. No questions.
just one question from my side. What did you do initially? Did you do any Monto tests or do you do any DMSA since you were suspecting a stricture?
Montu was done, sir.
And what was the
But
AP diameters initially? Yeah, sorry.
sir, Montu was done, and sir, histopathology was also sent in view of the malignancy.
But
This stricture
Monto
was
was
arising.
positive initially because I think you directly went on with a diagnostic lab.
No, sir. Sir, we followed the protocol, but because for the sake of brevity, I have not mentioned all the investigations, sir.
Okay.
Yes.
And did you do a DMSA pre-op?
Yes, sir. Sir, DMSA was also done.
And the functions were fine. There was no scar, right?
Yeah, yes, sir. Renal function was.
Okay. Thank you. Nice presentation.
Thank you.
Can we move on to the next presenter, please? Next presenter is Isha Ashok. Please, your slide is visible. Please unmute yourself and start the presentation.
Hello, good afternoon, sir. Can you hear me?
Yeah, you're audible.
Good afternoon, sir. My name is Dr. Isha Ashok. I'm presenting on prognostic markers in patients of posterior urethral valve, a prospective longitudinal study. So as we all know that PUV is a common cause of bladder outlet obstruction, and the increased pressure in the bladder is passed on to the pelvic calyceal system, and the kidney is the one which bears the brunt of the disease. So there are different studies which have different opinions based on the prognosis. For example, Parkhouse et al. Believes that a person presenting before 1 year of age has 41% chance of developing poor renal outcome compared to someone who is presenting after 1 year who has only 15% chance of developing poor renal outcome. But Saran et al. In his study in Nigeria believes that there is no correlation as such. So there's not much data available in our part of the country, and with this study, we wish to fulfill that gap. So I've done this study at RIMS Ranchi over a duration of 6 months, and we've included 38 patients. We have used the Schwartz formula for calculation of the eGFR, and the data was entered in Excel, and analysis is done using SPSS. Inclusion, we have included patients less than 14 years, and exclusion, we have excluded patients who are on ACE inhibitors or alpha blockers. So the observation was that the mean age was 25.71 months with a minimum of 0 and maximum of 120 months. The height was mean of 77.624 centimeters with a minimum of 34 and 136 centimeters maximum. eGFR was a mean of 31.505 and minimum was 7.3 ml per meter squared and maximum was 69.7. So the most common symptom was dribbling of urine. SIRS was present in 7.9% patients. The ultrasound findings showed hydronephrosis was present in 100% patients. We did not find any cases of patent urachus. E. coli was the most common pathogen found in the urine culture sensitivity. The surgical intervention could not be done in 7.9% patients as we could not bring them up to surgery. They were not hemodynamically stable. Fulguration was done in 92.1% cases and vesicostomy was taken in 13.2% patients. The time interval between these two procedures was a mean of 32.60 days with a minimum of 5 and maximum of 125 days. Chronic renal failure was found in 1 patient, that is 2.6%, and mortality was seen in 3, that is 7.9% patients. With reference to vesicostomy versus non-vesicostomy, we found that the mean age at vesicostomy was 79 months, and in the mortality group, it was 33.60 months. The pH in the mortality group was 6.9 compared to 7.2 in the non-mortality group. With respect to vesicostomy versus non-vesicostomy, upon doing the chi-square test, we found that proteinuria only had the significant p-value of 0.0089. In the mortality versus non-mortality group, prenatal diagnosis was done in 66.7% patients in the prenatal in the mortality group, whereas it was done only in 11.4% patients in the non-mortality group. Even then, the p-value was not significant for the prenatal diagnosis, whereas it was found significant for the proteinuria and SIRS group. So The discussion is mean age at presentation was 25.71 months. Mean age at mortality was 3.67 months. And in the vesicostomy, it was 79.20 months. Prenatal diagnosis was made in 4 and in 2 in mortality group. SIRS was present in 7.9% patients. E. coli was the most common pathogen. Proteinuria was present in 23.7% patients. A higher age is associated with vesicostomy, whereas mortality is associated with lesser age at presentation. Prenatal diagnosis was associated with worse prognosis. Higher creatinine is associated with mortality, whereas no such difference is found with respect to vesicostomy. Less sodium, less chloride, more potassium, less GFR, and less pH is associated with mortality, and no such relation is seen with vesicostomy. Proteinuria is a significant predictor of vesicostomy and mortality, and SIRS is a predictor of mortality. Thank you. These are my references.
Thank you, Isha, for your nice presentation.
Thank you, sir.
Dr. Arun and Dr. Prabhu, you have any questions for her?
Nothing from my side.
Dr. Prabhu?
Yeah, we can. Doctor, apart from this one, what other prognostic tests that you can think of, apart from what you have mentioned?
So we can go
How would
for
you counsel the patient?
beta 2 macroglobulin. Then we can go for the urine osmolality. Also, we can go for any pop-off mechanisms. Like we did not have proper documentation of the pop-off mechanisms in all the patients, so I have not added all those here. But beta 2 macroglobulin, urine sodium, urine chloride, and osmolality is
You
what.
do the imaging of imaging.
Yes, sir. We
Do
had
imaging?
imaging modalities. We had hydronephrosis. We had PUGO.
No, no.
Whether there
Anything to
was any
do
patent uricus,
with the
that was done. But with respect to pulmonary hypoplasia, I did not find that documented in every case sheet. So that I have not included in my study, which I could have added.
Did you guys try
One more.
any biomarkers or anything of that sort?
No, sir. That whatever investigations we have done are done free of cost, and beta 2 macroglobulin is not done at RIMS Ranchi free of cost. So we have not included that in our study, but we are trying to get that for academic purpose.
Got it.
Isha, there's one question in the chat box. If you can
Yes,
answer
sir.
that. Do you know what's nadir creatinine?
Yes, sir. The creatinine, which is done till 1 year of age, if it is less than 0.8, we feel that there is good prognosis. And if it is more than 1.2, we feel that there is bad prognosis and prediction of poor renal outcome.
And you, in your study, did you study this as well?
No, sir. We have done only till 6 months of follow-up. And from what I have read, you have to do at 0, 1, 6, and 1 year of age. So since we did not follow up for a long duration, I have not included that in my study.
Just one small question from my side. You
Yes.
said in your study that the prognosis was worse in the patients who were, identified later. So did you study in antenatal cases that you picked? Was the SFU grading of the same studied in your study as well?
No, sir. From my study, we have predicted that if a patient is diagnosed antenatally, then the prognosis poor. Because these patients, generally, we don't have a lot of follow-up for the ANC things in our part of the country. So the patients who have presented have already had some sort of a complication in their ANC follow-up. And because of that, they are predicted. And the 3 patients that have landed up with mortality, we had prenatal diagnosis in all of them, and we could not hemodynamically stabilize those patients to take them up for maybe fulguration or any other procedure. So I think prenatal diagnosis, according to our study, is associated with a poor prognosis.
Okay. And just last question, a
Yes,
quick
sir.
one. So you said the later stages, the vesicostomy chances were
Yes,
more, right?
sir.
Not
Yes, sir.
wrong? So do you know, can you suggest any indications for vesicostomy in early neonatal age?
So what we do usually is we first take up the patient for fulguration, and intra-op we put suprapubic pressure, the Curdy's maneuver. If the urine output is not good, then 5 days later we also see the metabolic abnormalities. If the patient is still in acidosis or the urine output is not good, then we take up these patients for vesicostomy. So that is the protocol that we follow here at RIMS at present. I think that could be good enough to take up.
The discussion is exceeding
Thank
the
you.
time.
Thank you.
Yeah.
Thank you,
We'll
sir.
head on to the next one. Thank you.
Thank you, sir.
Yeah, am I audible, sir?
Yeah, you're audible. Please go ahead with the presentation.
Good afternoon, everyone. This is Dr. Maunika from Sri Ramchandra Institute of Medical Sciences. I am DM resident in Neonatology, and my moderator being Ramesh Babu sir. He is pediatric urologist. And my study is on, do all preterm posterior urethral walls need diversion? Coming to it's not coming. Coming to my aims and objective, it is to evaluate the effectiveness of the management of preterm posterior urethral wall with primary valve ablation and to correlate the antenatal sonographic risk factors and its postnatal outcomes in preterm PUVs. And we have conducted this retrospective analysis in preterm neonates diagnosed with PUV over a decade from 2013 to June 2022 in level 3 NICU in SRMC Chennai. And antenatal data were collected like gestational age, risk factors such as liquor and the renal echogenicity. And based on the modified Warner classification, we have classified into low risk, intermediate risk, and high risk. Coming to low risk, we have categorized under low risk if AFI and renal echogenicity were normal, and intermediate risk if there is any oligohydramnios with normal echogenicity, and high risk if there is anhydramnios with abnormal echogenicity. There are total of 29 neonates presented, managed between 2013 to 2023, both including term and preterm, out of which 8 were preterm neonates. And coming to results, like under low risk category, we have 1 neonate with gestational age of 36 weeks plus 4 days. And anomaly scan done between 22 to 22 weeks has shown normal AFI with bilateral UTDA 2 to 3 with keyhole sign. And postnatally, baby was managed with elective primary valve ablation. And baby doesn't require any respiratory support. Coming to intermediate risk, there are 5 neonates with gestational age between 32 to 36 weeks, where anomaly scan done between 22 to 22 weeks has been shown oligohydramnios with bilateral hydrouretronephrosis with keyhole appearance. Among them, 3 neonates were managed with primary valve ablation, whereas 2 neonates had urinoma. So we have stabilized them with percutaneous nephrostomy before undergoing primary valve ablation. And this is the slide showing endoscopic appearance of PUV in the first image. That is the first image where we can see walls at 5, 7, and 12 o'clock positions. And this is the second image where we can see the blue spot indicating the laser fiber at 7 o'clock position with which we have fulcrated the PUV walls. And we have used 4.5/6 French cystoscope. Generally in term neonates, we'll be using 9/9.5 French resectoscope. And coming to high risk category, we have 2 neonates with a gestational age of 32 weeks and 33 weeks, in which first neonate had anhydramnios with right side multicystic dysplastic kidney with left hydrouretronephrosis with keyhole sign. And second neonate has anhydramnios with bilateral hydrouretronephrosis. And both the neonates required ureterostomy diversion procedure due to poor renal function. So we have followed for 6 years, and low and intermediate risk patients, that is total of 6 patients, have stable renal function, whereas high risk neonates 2 have poor renal function. Among them, 1 patient had ureterostomy closed on medical treatment, second patient still on ureterostomy awaits renal transplant. Coming to conclusion, primary valve ablation is safe in low and intermediate risk preterm neonates with good long-term renal outcomes. Whereas with those with urinomas, primary valve ablation after temporary drainage is effective. Whereas poor risk factors based on ultrasound determinants of the long-term renal outcomes and are the probable situations where temporary diversion is needed in the current era where miniature cystoscope ablation facilities are available. Thank you.
Thank you for a really nice presentation. Any questions, Dr. Arun, Dr. Prabhu?
Yeah. If the child is having a preterm and you don't have the appropriate scope, what are the other alternatives?
Like we can do any diversion processes, like vesicostomy or ureterostomy can be done.
Without doing diversion, is there any other option? It's not quite rarely used, but it's available in SRMC.
Bugby laser.
No, for the children of 32 weeks, probably you can't even put a stethoscope inside. You won't have the appropriate size scope.
Yes.
So,
Valvotomy.
yeah.
Mohan's valvotomy is.
Yes, Mohan's valvotomy. Yeah.
So, doctor, tell me, in these cases where you have a little bit of, when you have difficulty, in all these cases, you can catheterize the child and leave it for a long time and do the procedures after maybe the child is grown up a little bit, maybe after 3 months or 6 months. Why are you not doing that, doctor?
Sorry, sir, I couldn't get it. Not.
Can you hear me?
Sir, now it is audible.
Yeah. If all the children, when you're considering they're very small and the urethras are very small, the scopes are a little bigger, or whatever your concerns are, you can catheterize the children for the next 3 months or 6 months, keep them on catheter and do a fulguration. Why are you not doing it?
There will be risk of any urosepsis due to that.
Only that is the only that is a factor?
And upper tracts won't be improved because of that.
Okay. Okay. The other question is, apart from whatever you looked at, even including the oligohydramnias and the renal factors, apart from the lungs, what else you would look at in an antenatal scan in PUs?
How is the bladder? Like
Exactly. Something related to bladder?
posterior.
What is the bladder that you would look for? You already mentioned the keyhole sign. That's fine. But what else you would look at?
Like bladder wall is thickened or not?
That is fine. Then only you can see all the whole signs and all. Cycling. Cycling of the bladder.
Sorry, sir.
Bladder cycling every 30 minutes, 25 to 30 minutes.
Okay, sir.
Okay. Thank you, doctor. Good presentation.
Thank you, Manika. Nice presentation.
Thank you.
Can you move on to the next presentation? It is by Madhavaraj.
Yes, sir.
Your slide is visible. You are audible. Please start the presentation.
Good afternoon, everyone. My topic for today's presentation will be pseudo-hypoaldosteronism due to bilateral ureteric stenosis.
Madhav,
in
you
a 6-week
have to decrease the volume of one of the devices because it's echoing right now. Can you talk now? One is muted. The one you are using is muted. Okay. Please unmute yourself.
Yes, sir.
Yeah, please go on.
So my topic for today's presentation will be pseudo-hypoaldosteronism due to bilateral ureteric stenosis in a 6-week-old infant. I am from PSG Hospitals, Coimbatore, and I'll be presenting under the guidance of Dr. Pavai. So here I'll be presenting a case of a 48-year-old infant who presented with polyuria, failure to thrive, and dehydration. On examination, the child had a mass that was palpable in the right upper quadrant. The child had a history of antenatally detected hydronephrosis, for which ultrasound done on day 1 of life showed a significant dilatation present. A follow-up MCO was done on day 7, which was found to be normal, and a dynamic renal scintigraphy scan for both right and left sides revealed that there was a right side small hydronephrotic kidney which had severely impaired perfusion and a left side enlarged hydronephrotic kidney with preserved parenchymal function. So on workup of the case, initial CBC and CRP done was normal. Serum electrolytes done showed severe hyponatremia and hyperkalemia of 109 and 6.92 respectively. Urine culture growth showed a mixed growth of ESBL organism and pseudomonas, which was significant. And ultrasound showed moderate to severe right hydronephrosis with mild hydroureter and mild to moderate left hydrouretronephrosis with bilateral mid-ureteric stenosis. So the possibilities that we considered while managing this case were initially sepsis-related electrolyte imbalance, congenital adrenal hyperplasia, hypoaldosteronism, and pseudo-hypoaldosteronism type 1. So sepsis-related electrolyte imbalance were ruled out because of the blood workup that was negative. Congenital adrenal hyperplasia, we sent a 17-hydroxyprogesterone level, which was found to be normal. Hypoaldosteronism, the levels of serum aldosterone and renin levels were sent, and it was found to be very high. So a possibility of pseudo-hypoaldosteronism type 1 was considered in this child. The child was managed with IV fluids, hyperkalemia measures, IV antibiotics, and fludrocortisone. Baby was medically stabilized by the 4th day of admission, and the baby was taken up for surgery underwent left uretero-ureterostomy and USG guided right nephrostomy, followed by a week later, right uretero-ureterostomy with BJ stent placement. Baby settled, currently is doing well after 2 years and is not on any medications right now. So what I would like to discuss about this topic is that severe hyponatremia with hyperkalemia and dehydration is an uncommon but life-threatening occurrence in infancy. So unless there is a clear evidence of GI fluid loss, adrenal conditions have to be considered very high on the list of differential diagnosis. Major diagnoses in this group include congenital adrenal hypoplasia, isolated aldosterone deficiency, any exogenous medication administration, and pseudo-hypoaldosteronism. Clue to diagnosis in this case is that the normal 17-hydroxyprogesterone level and increased levels of aldosterone and renin. So secondary pseudo-hypoaldosteronism can cause renal tubular resistance to aldosterone, and this can lead to significant electrolyte imbalance, and the child may present with failure to thrive and dehydration. Despite levels of the elevated aldosterone and renin, there is transient unresponsiveness to aldosterone, and the pathogenesis is very ambiguous. It could be due to age-related issues, urinary tract obstruction, and infection. And also there is genetic etiology in younger than 6 months age group suspected. So they can have immature renal tubules, obstruction or reflux, which can increase the intrarenal pressure and downregulate the number of aldosterone receptors, and intrarenal synthesis of cytokines may inhibit the action of aldosterone. So concluding on my presentation, congenital hydronephrosis and ureteric stenosis can lead to urinary obstruction, causing back pressure on the kidneys and impairing their function, thus can lead to secondary pseudo-hypoaldosteronism. If not identified, it can present with complications as in our child, but was managed timely. So in our case, the serum aldosterone and renin levels done at follow-up were found to be normal, in the normal range. Thank you.
Thank you, Madhav.
Time managed well.
Okay.
He was within time.
Okay, thank you. Dr. Prabhu, Dr. Arun, you have any queries for him? Any questions?
If you don't have any questions, see. Oh, sorry.
Yeah,
So
please.
doctor, why didn't you, I mean, you had obstruction on both the sides. Why didn't you operate the child on both the sides?
Sir, actually on the initial scan done, the left side kidney had showed preserved function, sir. So that's why we took one by one, yes, sir. So the right was operated first and the left was operated later, sir.
Any specific reason, doctor? There are two sides. You are a surgeon. You can complete the surgery on both sides. Why did you take one by one? What would be? Yeah, I'm done with the question. Thank you.
Yeah, Dr. Arun.
Was stenting attempted before doing the procedure?
Yes, sir. Stenting was attempted, sir. Yes, sir.
Both sides it was not able to be passed.
Not both sides, sir. Only on right side was done first, sir, under ultrasound guidance.
So we have done uterostomy on the other side, and the stenting was not attempted on the other side. Directly we went ahead with nephrostomy.
Yes, sir. Yes, sir. Because the ureteric stenosis was being a rare presentation on right side, it was confirmed with stenting, and then left side it was operated directly. Yes.
Yeah. Okay. Got it. Yeah.
Thank you. Thank you, Madhav. Can we move on to the next presentation, please?
Thank you, sir.
Aruna, your screen is still loading. Are you there? Is anyone able to hear Aruna?
No, not able to hear.
I think we can go on with the next presentation first and then have her again after this.
Hello,
Can
sir.
we have Sharmila? Yeah,
Hello,
Sharmila. Who's this?
Aruna, sir. I'll just.
Okay, please try
One
again.
second.
Yeah.
Yes.
Aruna, your presentation is visible. Please switch it on to slideshow mode and start the presentation.
Sir, is it visible, sir?
Yeah, please start with the presentation.
Good afternoon to all. I'm Aruna from Srihar. Today, I'm going to present a topic on systematic review and meta-analysis on usefulness of transcutaneous electrical nerve stimulation in children with overactive bladder. To start with, overactive bladder in children is a common condition and which also has symptoms of urgency, frequency, urge incontinence, and daytime wetting, which leads to low self-esteem and depression in school-going children. Standard treatment for overactive bladder in children is conventionally treated with medical management like anticholinergics, which often causes troublesome side effects like constipation, pyrexia, and rarely cognitive disorders. Neuromodulation with transcutaneous electrical nerve stimulation is an alternative treatment for overactive bladder, which is devoid of any symptoms that medical management when compared to medical management. In this meta-analysis, we have assessed the efficacy of transcutaneous electrical nerve stimulation in the management of children with overactive bladder. Coming to the methodology, we did a systematic literature search in PubMed, Embase, and Cochrane Library, etc. for full text articles reporting treatment of overactive bladder comparing TENS versus control group. This meta-analysis was carried out using funnel plot, odds ratio, and forest plot were constructed using Review Manager version 5.4. Coming to the results, between 2008 and 2023, 380 abstracts were identified after excluding all those with incomplete, inadequate data, duplicate publication, and reviews. We came out with 8 articles which were included in this meta-analysis. Here is a visual representation of the systematic review through Prisma flowchart. Funnel plot showed systematic distribution. As we can see, the graph shows low publication bias. Coming to the 10 settings, majority of the articles had 10 settings of pulse width of 200 microseconds with a frequency of 10 hertz, and this lasted for 20 minutes duration and over a period of 20 sessions. Coming to the analysis part, to identify the effectiveness of TENS, it was divided into 3 groups, that is full response, partial response, and no response. In full response to treatment, patient had improvement. Patient had 100% improvement, wherein the odds ratio was 3.5 with 95% of confidence interval. This shows a positive association, so it favors TENS when compared to control group. In partial response to treatment, patient had improvement from 50 to 99%, and the odds ratio turned out to 2.28 with 95% of confidence interval. Again, it favors TENS when compared to control group. In no response to treatment, that is improvement that is less than 50% of improvement was seen in patients. The odds ratio was 0.3, which shows a negative association. So it favors control group when compared to TENS. Coming to the conclusion, I conclude that this meta-analysis shows TENS is effective in children when compared to control group. And limitations of this meta-analysis includes a small sample size and the short-term follow-up period. Thank you.
Thank you, Aruna, for this presentation.
And time was within limits.
Okay. Dr. Arun, Dr. Prabhu, any questions?
Yeah. Do you guys do TENS in there?
Yes, sir.
Before
Yes,
you
sir.
have done in your.
Yes.
What are the settings that you use?
We use pulse width of 200 microsecond, and frequency will be 10 hertz, and intensity will be according to patient's threshold, sir.
How many sessions?
20 sessions for a month, sir.
Just like what you have explained in that
Yes, sir. Yes,
meta-analysis.
yes, sir. Yes, sir.
Okay. Any other alternative modality of neural stimulation that you know of, apart from TENS?
Apart from TENS, sir, we have different types of TENS, sir.
Yeah. Yeah, what are the which area you will place the electrode in?
Sir, in this TENS, we'll be placing in sacral TENS, and we have posterior tibial TENS, sir.
Okay. Yeah. Dr. Prabhu?
Yeah. Apart from, see, doctor, you mentioned this TENS is used for overactive bladder, right? Is there
Yes,
any
sir.
other
Yes.
place you could use this TENS?
Sorry, sir.
Is there any other place you could use the same TENS?
So for they'll
Apart
be
from,
using this
yeah.
TENS in physiotherapy for pain relief, sir.
Okay, fair enough. And what you said 20 sessions. How do you
Yes.
space them, doctor?
So
How
when
did
I
you
came
space them?
across so many articles, majority of them have attempted 20 sessions, and it is effective in patients, sir.
Now, how do you space them? 20 sessions. How do you space them? Space in between the sessions.
Okay, sir. It is either 2 weeks, 2 days per week, or in some articles they have mentioned every day also, sir, for 20 sessions, sir.
Okay. Thank you.
Thank you, sir.
Thank you for the presentation. Can we move
Thank
on
you, sir.
to the next presentation?
Am I audible, sir?
Yeah, Sharmila, you're audible. Your presentation is visible. Please start with the presentation.
Yes, sir. So good afternoon to everyone. So myself, Dr. Sharmila, postgraduate from the Department of OBG, PSG Coimbatore, will be presenting on the topic pregnancy and delivery after augmentation cystoplasty. So let me brief to you about our index patient who's a 25-year-old primigravida with cloaca. So she had undergone various procedures like augmentation cystoplasty, Mitrofanoff, reimplant, bladder neck surgery, vaginoplasty, and she had come to us for safe confinement at 36 weeks of gestational age. So following which, we formed a team comprising of an obstetrician, general surgeon, pediatric surgeon, urologist, a senior pediatrician, and an anesthesiologist. So we as obstetricians, we decided on the mode of delivery, the timing of delivery. Incision was planned after looking out for the uterine position, the fetal position, the location of the augment with the help of ultrasound guidance. And blood loss was also expected to be on the higher side. So blood products were arranged and intimated about the same to the anesthesiologist. Okay, mine is there and next. An elective classical cesarean section was planned with the
Doctor, please continue. Sharmila, you got muted. Sharmila, please unmute yourself. Yeah.
An elective classical cesarean section was planned with the presence of a pediatric surgeon, urologist, and a general surgeon, and a senior pediatrician. So procedure was done under general anesthesia. Intraoperatively, catheterization of the Mitrofanoff to delineate from the surrounding structures. Filling of the augmented bladder was also done. So as you can see in this picture, an abdominal incision was planned in such a way so that we had to obtain adequate access, and hence a midline laparotomy incision was planned. So as we had anticipated, there were bowel adhesions which were released with the help of a general surgeon, and vessels supplying the augment were found to be stretched over the lower segment of the uterus. Hence, a classical upper midline incision was made. Baby was delivered by breech extraction. Augment was then checked for its integrity. Our augment was intact, luckily. But even if injured, repair the augment and let the drain be in place for adequate period to allow healing. So what is augmentation? A small bladder is being converted into a bigger bladder. It's a safe and an effective way of improving urinary storage with renal protection. There are 3 types of augmentation surgeries: sling, division, and YDL. So total number of augmentation surgeries done at our institution is 117, out of which 52 were bladder neck surgeries. And number of females out of these 52 were 42. So we can thus expect all these 42 patients in our OPD for their antenatal checkup. So 4 out of these 42 patients have come back to us for their deliveries, and all of them have been success stories. So coming to the literatures that were reviewed, no proper consensus have been given regarding the mode of delivery. In a study involving 102 patients who have undergone augmentation cystoplasty, around 72 had normal delivery, but 1 out of those 72 had urinary leak. So LSCS was done in 29 patients, and 13 were obstetric indications in them. So literature regarding patients who have undergone bladder neck surgery reconstruction is still not very clear. So final thoughts is women who have undergone augmentation can still have a healthy reproductive life. Counseling is to be done before planning the pregnancy, and common complications include urinary tract infection and hydronephrosis. Monthly urine culture and early treatment of this UTI has to be done in order to prevent preterm labor in these patients. Obstetrician should monitor the urine and the renal function. Augmentation cystoplasty is definitely not a contraindication for vaginal delivery, but though it may not be very optimal for those who have undergone bladder neck surgery. Again, research is required in this regard. So when performing LSCS, pre-op imaging and a pediatric surgeon, urologists need to be present intraoperatively. So these are my references. Thank you.
Time exceeded by few seconds.
Okay.
Yeah.
Thank you so much, Sharmila, for a really interesting presentation.
Thank you.
Any questions?
Yeah, very nice presentation and very nicely managed, Dr. Sharmila.
Thank you.
And I have a few questions. What is the indication that the child had to undergo augmentation before in childhood?
She had a small bladder with recurrent sphincter incontinence, sir. She had
I mean, cloaca surgery.
cloaca, yes.
Okay. Where was the mitrofan of opening placed?
It was
Is it
placed
umbilicus or outside the umbilicus?
outside the umbilicus, sir.
The right iliac fossa region.
Yes, sir, right iliac fossa.
All right. All right. Was there any difficulty during the pregnancy for catheterization? Any symptoms
No,
that the patient was able to?
She had UTI, which was managed with antibiotics based on the culture sensitivity. Other than that, she did not have any complications regarding to her voiding and catheter.
No difficulty in catheterizing
No
via the
difficulty
mitrofan during the
catheterization.
pregnancy.
We had the pediatric surgeon intraoperatively. We had Dr. Pavai who did the catheterization of the mitrofan for us intraoperatively. And the surgeon who had done the mitrofan was also present with us intraoperatively.
Thank you.
Thank you, sir.
Doctor, you said your indication for this, I mean, would you suggest this cesarean section for all the children or all the women who has undergone an augment with mitrofan, or is there a specific indication?
When the patient has undergone bladder neck surgery, then we would advise LSCS for those patients, because in literature there has been one patient who has got urinary leak post normal delivery. So we've made the bladder. Yes, sir.
Go ahead, doctor. Go ahead.
There can be a stretching of the bladder neck while delivery, so which can again lead to urinary leak. So in such patients who have undergone bladder neck division surgeries can be recommended for LSCS, sir.
So what about your second, after LSCS? Yeah, okay. See, you said the commonest complication that you have is a UTI in this kind of patients.
Yes, sir. Yes.
So if is more expected even in reflex, I mean, patients having vesicular reflex too. So what antibiotics? I mean, these patients would need a long-term antibiotics throughout the pregnancy. So what antibiotic would you suggest in general, doctor?
Nitrofurantoin, sir.
Okay, fair enough. Is recommended as well. That's my question. Yeah. Thank you, doctor.
Thank you so much.
Really nice presentation. Thank you.
Thank you, sir.
Can we have the next presenter, please? Arusha, your slide is visible. Please put it on to slideshow mode.
Yeah.
And you're audible. Start the presentation.
Good afternoon, everyone. My paper is on comparison of outcomes of distal hypospadias repair using extra coverage of new urethra with single versus double Datos flap at IQ City Hospital. I'm Dr. Arusha, and I've done this under the guidance of Dr. Chandrasekhar Singh. The aim of the study is to compare the outcomes of coverage of new urethra with single versus double Datos flap. As we all know, the definition was a congenital condition where the urethral meatus is located on the undersurface of the penis. There can be 3 different types based on the location of the urethral meatus, that is anterior, which is distal, middle midshaft, posterior proximal. Prevalence is around 1 in 200 to 300 live births globally. The cause is in fetal development during the 8 to 14 week due to incomplete closure of the urethral folds. The risk factors are genetic factors, maternal factors such as advanced maternal age, diabetes in pregnancy, and environmental factors such as phthalates and PCBs. The study design, it is a prospective study. The study setting was IQ City Medical College. Duration was 2 years.
You are muted, doctor. You are muted.
The duration was 2 years. The participants were 45 male patients with distal hypospadias. The inclusion criteria was male patients more than 6 months of age with coronal, subcoronal, distal penile hypospadias, which are near to corona, then midpoint of penile shaft. The exclusion criteria was redo procedures, proximal hypospadias, and those proximal to midpoint of penile shaft. Study tools used were a pre-designed questionnaire to obtain socio-demographic examination findings and outcome data. Average hospital stay was around 14 days for all patients. Surgical technique was double or single Datos flap coverage. Out of 45 patients, 25 patients underwent double Datos flap, which is 56%, and 20 patients underwent single Datos flap, which is 44%. These are the operative steps. In the first step, we can see raised Datos flap from Byers flaps. The second image, it shows a single Datos flap coverage, which is done on a conduit, which is the catheter. And the third is a double Datos flap coverage, which was done. The result was, the first was the uretrocutaneous fistula, which is the most dreaded complication, which was only seen in 1 patient in double flap category. None in single flap developed it. Penile skin edema, mild penile edema was seen in 14 patients in double flap and 12 in single flap, and moderate 11 in double flap versus 8 in single flap. Skin necrosis was seen in 2 patients only in the double flap group, and the mean satisfaction scores was 8.2 plus minus 0.9 in double flap, which was comparable in the single flap, a little better in single flap, which was 8.4 plus minus 0.8. The discussion goes as traditionally double Datos flap has been considered to be superior to single Datos flap for coverage of new urethra and decreasing complications like the UCF. In our study, we found both the methods to be statistically comparable with slightly better results in single Datos. If single Datos is raised with adequate thickness and vascularity, incidence of complications are much less. Skin-related complications are much more in the double Datos group owing to the devascularization. Moreover, in some cases, Datos tissue is deficient and it is not possible to raise the double Datos flap. Thank you.
Thank you, Arusha, for an interesting presentation. Any questions, Dr. Arun?
Yeah. Just before going into the details and the distal hypospadias, as you said.
Yes.
What was the how did you confirm the diagnosis of distal hypospadias before or after the surgery, after degloving or before degloving? How did you do?
So we confirmed it during the degloving, but beforehand on examination also we were assessing, and then during exposure after the skin incision when we were exposing in degloving, we confirmed the urethral meatus position at that point.
So you had excluded the children after degloving if they have become proximal. Is that what you're saying?
So actually, we did not find any such case. All the 45 patients, all of them presented with a distal penile hypospadias. We did not get such a case actually.
You do routinely do a Gitti's test to confirm the CODI and everything?
So we were actually post degloving in most of the patients, the CODI correction was done. If it was not done in 1 or 2 patients, then we did a Gitti's test to confirm the CODI correction.
So you had done all the patients you have taken. You have done only the flap coverage.
Yes, sir.
Yeah.
CODI was already
yeah, I also noticed that in the inclusion criteria, you mentioned about more than 6 months of age for the surgery of hypospadias. What is the average age that you guys do during the surgery? When you take up for the surgery? What is the age that you take up for surgery in hypospadias usually in your
here in our institution, we take up between 6 to 12 months of age.
What was the youngest you have done so far?
It's a 6, not below 6. We haven't.
You've done in 6 months itself?
Yes, sir. 6 months.
Okay. Did you happen to notice any flap dehiscence or any complications of that sort?
So we found UCF in one case of double Dato's flap. Wound infection or
Glance
dehiscence
dehiscence,
was
nothing.
no, we did not find, but we did get meatal, a little slight kind of stenosis which healed on its own. There was no major complication in the flap coverage.
And you also calibrate postoperatively.
Sorry, sir?
Do you do
Yes, we
calibration
do yes, every few days.
routinely?
Yes, routinely.
Yeah. Thank you.
Doctor, if I can ask you,
Yes.
you spoke about the daughters, right, to cover the urethra.
Yes.
Can you tell me any other tissues that can be used to cover the urethra apart from daughters?
So buccal mucosa is sometimes used.
Something native? Yes, by buccal mucosa used to cover.
Sorry,
No?
sir?
Something native there, available there,
Something
right
like
at the penis,
easily available.
close to penis. Thank you, doctor.
Tunica vaginalis you use?
Yes, so we can use tunica vaginalis.
So just one question from my side. Your mean hospital stay was around 14 days.
Yes,
So
sir.
what's the average period where you take out the catheter for this?
So on most cases, we took it out on the 10th post-op day.
Okay. And
And we
you
checked for the flow of the urine.
and you keep them after the removal of catheter as well in your hospital?
Yes, we kept them. Single average day was actually 12, 14 I've kept because most cases were discharged after day 14, but mostly after the 12th day, we have discharged them with oral antibiotics.
Okay, thank you. There's one question from Dashmeet sir. You can answer that in the chat box. Is about have you used a buttonhole dartos from the hood? Since we are running out of time, you can please answer this thing in the chat box if there is any experience. Thank you so much. Yeah. The last presentation for this session.
Yes, sir.
Akanksha, please share your
Yes.
screen. Yeah. Yeah, your slide is visible. Please put in. Yeah, you can start.
A very good afternoon to everyone. I am Dr. Akanksha Mehra, third year PG resident from Department of Surgery, Netaji Subhash Chandra Bose Medical College, Jabalpur. And I would like to share my experience of hypospadiology as a golden opportunity for general surgery residents to master general surgical finesse. So what you see on your screen are images of 4 surgical procedures that are very commonly encountered by, assisted by, or operated upon by general surgical residents and require a high surgical aptitude. I, during my general surgery residency, was fortunate enough to carry out my thesis in the subspecialty of hypospadiology, which is the art and science of surgical repair of hypospadias. And as Dr. John Duckett would say, it is a difficult science which is humbling and energy consuming. So during my pediatric surgery rotations, I realized that hypospadiology is a complex and a challenging procedure. And it is safe to say that there are as many ways to repair a hypospadias as there are the number of cases, thus requiring a very high degree of degree of subjective decision making for each case. Hypospadiology requires a high degree of precision and tissue handling in order to avoid tissue necrosis, ischemia, and trauma to the delicate penile and urethral tissue. It requires fine suturing technique and improved hand-eye coordination, which are both very important in today's era of laparoscopic surgery. Placement of tension-free sutures is essential in procedures such as tubularized incised plate urethroplasty in order to prevent necrosis and dehiscence of the glands. It also provides exposure to the basic principles of flaps and plastic surgery dissections. While assisting and observing on these cases, I realized that loops are a boon to human mankind as they enabled finer tissue handling by providing better magnification of the intricate anatomy. Hypospadiology and pediatric surgery rotations have also enhanced my problem-solving skills by teaching me to learn, anticipate, and prevent complications both in the intra-op as well as the post-operative period. So, did you know that the anatomy of the prepuce is very complex with very variable patterns of the vascularity, and preservation of this vascular anatomy is highly important to prevent flap necrosis and dehiscence in procedures such as Duckett's onlay urethroplasty. Now, what you see on your screen is an image of a vernier caliper, something that all of us have used during our physics laboratory classes while we were in school. I, however, during my first year of general surgical residency, ended up ordering a pair of these vernier calipers in order to measure the length of the tissue that we reconstructed in hypospadias repair, because in a surgical procedure, every millimeter of a tissue counts. As Dr. Hadidi once said, that learning occurs in 3 phases. First, you read what others say, then you repeat what others say, and then finally you learn to question what others have to say. During my dissertation on hypospadiology, I learned that you can also mathematically learn, mathematically measure what you are learning, and this can be applicable to various other procedures. And contrary to the belief that TIP is a easier procedure to perform than Duckett's-Onlay urethroplasty, in my dissertation, I realized that Duckett's-Onlay urethroplasty is technically as well as mathematically easier to learn, as well as to replicate, as can be shown by these graphs. Hence, I would like to conclude by saying that hypospadiology is an ever-evolving and expanding specialty, the principles of which can be applied to procedures such as bowel anastomosis, MRM, as well as hernioplasty, which are the bread and butter of a general surgeon. Hypospadiology has provided a gateway for general surgery residents to learn fine suturing techniques, tissue handling, vascular preservation, as well as magnification, and serves as an excellent platform to enhance surgical skills, broaden surgical perspectives, and understand the needs of the patient and their families, and have a greater impact on the patient's lives. Thank you.
Thank you, Akansha, for a really inspiring kind of talk. Is there any question from Dr. Arun or Dr. Prabhu?
Nothing much. I just want to congratulate Vikesh sir for giving them amazing exposure regarding hypospadiology. Doctor, have you tried the loops in your post-graduation times when you're assisting hypospadias?
Not very regularly, but I have had an experience of using loops.
You had how nice it is to wear a loop during surgery.
Yes.
How many cases probably you would have assisted hypospadias?
Since hypospadiology was my dissertation, maybe around at least 30 or 40 I have assisted on.
Okay, one last final question. Probably, I hope you said the right answer. What super specialty are you going to take? Thank you.
Dr. Prabhu, any questions?
Very nice. Yeah. Your dissertation being hypospadias, doctor, it's very nice to hear from younger surgeons. So your dissertation being that it's already a repeated question. What is an ideal age for hypospadias repair as per the current guidelines and recommendations, both from American Pediatric Associations or American Urological Association? And currently,
6 months
we do have
to 2 years.
Why is that so?
If we go beyond the age of 2 years, so basically the child develops a sense of his own body parts, his organs. So it could have a psychological impact on the child.
Thank you.
Thank you. I think congratulations to your department for motivating general surgical residents. Did you get to do a hands-on on any of the cases, or it was mainly assisting? And did you see?
It was mainly assisting and observation, but I was allowed closures, like skin closures. I was allowed.
Okay. And did you get to assist any more cases beyond like tip or ducats? Any
Yes,
other?
yes, magpie buyers, and there is tubularized unincised plate urethroplasty that we also perform commonly. So I've been assisting on those as well.
Okay. Thank you so much for your really nice presentation.
Thank you, sir.
With this, we conclude the session on urology. Next up, we have a session on core pediatric surgery. I would like to thank my co-chairpersons, Dr. Arun and Dr. Prabhu, for sparing out their time and adding value for us. And now I'll hand it over to Dr. Vinay to moderate the session ahead.
Thank you all, guys. Really brilliant show. Thank you.
Dr. Tanmay, I would like to point out that D7 and D9 have not yet joined for the next session. Rest all are there. Quite a few of them are yet to be made co-host.
Okay, I'll do that straight away. Yeah, we can start with D1. I think I have made them the co-host.
D1 and D2 are ready.
Yes, please start. Okay.
Soma Vishwasar and Rupa Banerjee, ma'am, are you there?
Yes, we are here. We are here.
Okay,
Vinay?
Chinna,
Yes,
you can
okay.
start your presentation.
Hello, am I visible, sir?
Yeah, you.
Is the screen
Yes.
visible?
Yes, yes.
Yes. Good afternoon, sirs and ma'am. I'm Dr. Chandni, finally a postgraduate from the Department of General Surgery. Today, I'm presenting a paper on ovarian torsion in prepubertal girls, our clinical experience. My guide and the pediatric surgeon is Dr. Mukavalli Srinivas Rao, sir. We are from Maharaja Institute of Medical Sciences, Vijayanagaram. Introduction. 30% of ovarian torsion occurs in less than 20 years of age. It's an emergency, but the diagnosis is often delayed due to the non-specificity of the symptoms. Mobility of the fallopian tubes is the root cause of its rotation. Right-sided torsion is seen more when compared to the left side because sigmoid on the left prevents from getting torted. Presence of any cyst or tumor increases the chance of torsion. Methodology, we choose about 5 cases with a main age group of 6 to 14 years. Location, right-sided ovarian torsion is seen in case of 4 patients, whereas left-sided is seen in 1 patient. The onset of symptoms is around 3 to 5 days. We performed laparoscopic procedure with only derotation was done in all the 5 cases using 3-port system in 3 patients and 2-port system in 2 patients, and the follow-up was done for about a year. So this is a table which shows a detailed structure where we can see all the cases were performed by using laparoscopic derotation only. Systematic relief was seen in less than 6 hours, whereas a varied recovery from the torsion, we can see the case 5 have taken 10 days to recover, whereas case 3 has shown about 4 months to get to the normal appearance. So according to the recommended guidelines, derotation only, derotation plus or minus relook laparoscopy, derotation plus or minus oophoroplex of one or both the ovaries, partial or complete excision or deroofing of the cyst, cystectomy plus derotation. Even though malignancy is such a rare cause, tumor marker should always be done. Relook operations are done after derotation and while waiting for the serum markers if the case is alarming. So this is a case report which shows a larger amount of time for the normal appearance. A 12-year-old female child presented with pain in the lower abdomen quadrants and suspected to have ovarian torsion. The ultrasound shows left ovary is in mid-pelvic region with enlarged and peripherally displaced follicles. Minimal color uptake in color Doppler around 3.9 into 4 cm cyst is noted in the left ovary. The CT abdomen showed a twisted left pedicle with diminished blood supply seen. So we concluded that it was a torsion of the left ovary and we proceeded for laparoscopic detorsion. And baby was in regular follow-up every month with ultrasound scan. And after 4 months, we can see that both ovaries are normal in size and appearance with good vascularity. So the conclusion is that the clinical and laboratory features can be quite varied, but ovarian torsion should always be considered in any female child with acute lower abdominal pain. Ultrasound is most useful initial diagnostic modality, but absence of flow on color Doppler cannot always be present. Diagnostic laparoscopy at the earliest is indicated. Conservative approach is seen in children. Relook laparoscopy if required. The main aim should be preservation of ovarian parenchyma. Although malignancy is such a rare cause, serum marker should always be done. PEXI or not is yet controversial. The limitations is that this study arises from a small number of patients from a medium-sized center. However, this limitation inherent to the study of an uncommon disease in such a young population which requires urgent care. These are my references and thank you.
Very nice presentation. Ma'am, any questions?
Yes, thank you. Yes, Sheila, hello. So what do you know what is the golden hour for any kind of a torsion, testis or ovary?
Yes, yes, ma'am. Within 24 hours, ma'am.
So it is actually 6 to 10 hours. But here we can see in your cases that 4 to 5 days the diagnosis was made late. But still we could all preserve all of the ovaries because you have follow-up for them.
Yes,
so I think we should mark this that we can preserve
the ovary.
Yes.
because of a good vascularity, even when we do detorsion, not taking into consideration if it is a golden hour, yes, not to go ahead with oophorectomy. Okay,
Yes, ma'am.
okay, okay. Thank you.
Thank you, ma'am.
Sir, any questions?
My question is, what is the minimum investigation that you do? And do you do regularly CT, MRI or anything? Or which is the minimum investigation that you require?
Ultrasound color Doppler, sir. GOST color Doppler.
So in the case you've shown, you have done a CT. What was the indication for doing that CT?
Sir, the color Doppler was not suggestive that vascularity or twisted vascular pedicle was not clearly seen, sir. So for that, we have subjected the baby to the CT screening scan.
And CT could tell that.
Yes, sir. They showed a vascular pedicle. Yes, sir.
Okay. Usually USG is better for that purpose than
Yes,
CT.
yes, sir.
So that's okay. That's all right.
Okay.
Very nice presentation.
Thank you,
Did
sir.
she, Dr. Abhimanyus, did she exceed?
She exceeded time. I have put up in the group actually.
Oh. So now we'll move to the next presenter. Is Dr. Abhirami. Are you there?
Hello, sir. Can you see me?
Yeah, we can see you. Can you please
Is my
share your screen?
visible?
That's visible. Yes,
Is it on
we
slide
can
view?
see. Yeah, it's visible.
A very good afternoon to one and all present. I'm Dr. Abhirami from the Department of General Surgery of Sri Ramachandra, Chennai. And today I'm going to present on the usefulness of virtual reality in student teaching, patient counseling, and surgical planning of various pediatric urology conditions. I did this study under the guidance of Professor Ramesh Babu, sir, of pediatric urology. So to my introduction, virtual reality in surgery helps us to get an idea of the anatomical relations in a spatial plane with the help of the VR headset and the joysticks. In this study, we aim to analyze the usefulness of virtual reality in the treatment of pediatric urology conditions. Materials and method. Over the past 1 year, we collected the medical records of the patients for whom the virtual reality reconstruction was done. We assessed the usefulness based on the Likert scale in the following areas of anatomical delineation, VR tools, surgical planning, student teaching, and patient counseling. The statistical analysis given by the 3 observers was scored with the Cohen-Kappa analysis for the inter-observer agreement. How we went about this method is that we obtained very thin cuts of 1 millimeter thickness from the CT and MRI images, and we fed them into the immersive touch software, which is the VR software. From this, we obtained the virtual reality reconstructed images in a 3D environment, which could be visualized with the VR headset. Here you can see a video. This is a patient with bilateral Wilms tumor. She underwent a nephron sparing surgery following preoperative neoadjuvant chemo. You can see that the tumor is being separated from the rest of the kidney. The kidney was very soft, whereas the tumor had been hardened by the chemo. This is the preoperative exercise we had done in the virtual reality. You can see that the tumors are depicted in the green color, whereas the remaining normal kidney is in the brown color. You can see the depth of the tumor and the spatial orientation as well. We went ahead and did a 3D reconstruction and the 3D printing of the same tumor in the kidney. Postoperatively, the tumor that we excised was very much found to resemble the 3D printing of the tumor we had done, except for that tongue of tissue over there. This was the same as in both sides. So here you can see that we had it was useful. We also had a patient with a pelvic functional kidney who, following a trauma, had a rupture. In the CT image, you can see the urinary leak present. We also did a 3D reconstruction of these CT images, and you could see that it did not offer us much more significant information other than some vascular anatomy. So we went ahead and fed these DICOM images into the virtual reality reconstruction, and we got the virtual reality model in the 3D software. You can see that the urinary leak is depicted in the green color, the kidney in the brick red color, the dilated pelvis in the yellow color abutting against the uterus, which is in the pink color. The vascular anatomy and the mesenteric vessels are also very clearly depicted, giving us an idea of what to expect when we go in surgically. So my results, we did for 12 patients this VR reconstruction, and we surgically managed a patient with that bilateral Wilms tumor, the pelvic kidney with PUJ obstruction, the PUJ calculus with the perinephric abscess, a horseshoe kidney causing PUJ obstruction, 5 duplication anomalies, and a rectourethral fissure. All of these were managed surgically. We had a conservative management done for the renal corticocyst patient and a renal trauma with urinoma. CT-based VR, we had 11 patients, and MRI-based VR, a single patient. 3D printing was also done for one of the cases. The mean usefulness score is calculated at the Likert scale and found to be highly useful in the areas of anatomical relations, patient teaching, patient counseling, and student teaching, closely followed by surgical planning. The intra-observer testing was found to be kappa 0.8, which is statistically significant. So based on my results and the operative experiences, I'd like to conclude this presentation by telling that the virtual reality model is definitely useful in the areas of pre-surgical planning, helps to assess the relationship of the vital structures and the residual volumes of the organs following tumor excision. VR application in student teaching will be extremely useful as it helps to provide a safe environment for the students to practice in before they enter the surgical plane, and also useful in the areas of patient counseling. We can also use these models for craniofacial reconstruction. Selection of ideal cases will help to make this novel tool extremely cost effective. Thank you.
She's within
Nice
time.
presentation.
Yeah.
Any
Yeah, may
So,
I?
hello.
Yeah.
Yes, yes,
Yeah.
please.
Go on.
No, Dr. Shomuk, please.
So, do you know, is there any advancement like you can do this in real time? When you are operating, you are also having a VR set or something. Is there any advancement like that has happened over the world?
Yes, sir. Now it is started. It's called as the augmented virtuality, where you combine this virtual reality along with an augmented reality, providing a place where surgeons from all over the globe can tune in and join while doing the operating. Even a person from elsewhere can also help in operating on that particular patient.
Very well done. Thank you.
Thank
you.
I'll just say
Yes, ma'am, please.
it is very good in the cases where you showed the bilateral wilms or all these cases where we are doing nephron sparing surgery. This will be really very helpful if we are able to get it done more and more. Okay.
Thank you.
Nice presentation. Can you please tell the financial feasibility, what would be expected cost?
Sir, can't able to hear you, sir.
Can you please tell the financial feasibility, what cost should be?
Tell about
The cost of this.
the cost. So at present, because we're doing a pilot study, there is no additional cost to the patients. But in future, when this is a full-fledged part of investigation and workup, there will be a certain amount of additional cost, which will probably be less than a maximum of 10,000. But as of now, there is no additional cost.
Thank you. And we'll like to invite the next presenter, Singh Solanki. Are you ready?
Good afternoon, sir. Sir, am I visible?
Yeah, your screen is visible. You can proceed with the presentation.
Good afternoon. The title for my presentation is Varied Spectrum of Congenital Anomalies Requiring Pediatric Surgical Management and Their Outcomes, a 7-year experience from a Level 3 NICU of Northern India. Myself, Dr. Preeti Singh Solanki, DM Neonatology, 3rd year resident. So, congenital birth defect is an outcome of abnormal morphogenesis. As per WHO, these are structural functional anomalies that occur during intrauterine life. Low to middle income countries are estimated to account for more than 95% of congenital anomaly deaths, in which 2/3 could be prevented through surgical care. So recently, there has been a transition in causes of neonatal mortality towards birth defects. Data regarding birth defects from UP is still lacking despite having higher neonatal and infant mortality. So this was the first study addressing surgically correctable defects along with their treatment outcomes. This study also fills a crucial gap in knowledge of neonates with birth defects who receive the eligible treatment at the right place and right time. So the primary objective of this study was to determine the incidence in treatment outcomes among neonates with congenital anomalies requiring pediatric surgical management at SGPGI Lucknow. This was a retrospective observational study, and study duration was 7 years. All inborn and outborn live birth with congenital birth defects as per ICD-10 classification and requiring pediatric surgical management was included. Data was collected from hospital information system and medical files. So total neonates with congenital anomalies were screened and various parameters noted. And so total 3,734 neonates were screened, and in this 332 babies had congenital birth defects. So incidence of congenital anomaly was 8.9% at our center. Out of these 332, 126 baby required pediatric surgical management. So under baseline characteristics, most of the babies were outborn, and median age of admission was 3 days with median gestational age of 37 weeks, and median birth weight was around 2.7 kg. The most important maternal risk factor was oligoheteronemia, which was seen in 32% of mothers. And in drug history, a majority of women had history of homeopathic medicine intake, that is in 27% of cases, followed by warfarin and anti-epileptic drugs. Under system, most common abnormality was there in CVS in 33.4% cases, followed by gastrointestinal and genitourinary system. So total 126 babies were eligible for pediatric surgical management. Out of these 126 babies, 66 babies has anomaly in gastrointestinal system, in which tracheoesophageal fistula was the main anomaly in 38% cases, followed by CDH, biliary atresia, ARM, malrotation, abdominal wall defect. So these are the list of surgical conditions and procedure and final outcome. So the most common defect which was corrected was tracheoesophageal fistula through primary repair, followed by CDH and anorectal malformation. These were some of the other defects. And the second most common system which was surgically corrected included genitourinary system, in which surgery for posterior urethral valve and hydroureteral nephrosis was done. And some alarm.
Dr. Preeti, sorry to interrupt. We are not able to see your screen.
Okay.
Yeah. Now it's visible.
So, is it visible, sir?
Yeah, it's visible.
Okay. So the second most common system was genitourinary system, and babies were operated for posterior urethral valve and hydroureteral nephrosis. Under other system, CPAM and congenital lobar emphysema excision was done. So out of 126 babies which were eligible for pediatric surgery, 79 babies undergone corrective surgery. So 49 babies survived, that is 62% cases. Rest other went lama, and some expired. So the most common morbidity which was associated with death was CSD, which was seen in 36% of cases. And our incidence of birth defect was higher than previous study, that is 8.9%, because ours being a tertiary center, most of the complicated cases are being referred here. Outcomes were comparable to other studies. So it is concluded that this data reflect the steadily increasing burden of birth defect from northern state of India. There is a need to upgrade the existing facilities and awareness for timely referral of babies with congenital anomaly. These are my references. Thank you.
Sir, any questions and comments?
No, I'll skip.
So, Preeti, how are you attached? How are you working? How do you come across these cases?
Ma'am, I am DM neonatologist, third year.
Oh,
and
okay. So I wanted to know how you are playing a role. So we, as a team, if we keep working, so the neonatology team or the NICU, neonatology, and the pediatric surgeon, only then the success rate of these cases increases. Because as you have been presenting, because one of the baby is born with multiple anomalies. It's not just one. Like the anorectal malformation most commonly has cardiac anomalies, even the esophageal atresia. So all of these has to be managed with a team. So the neonatology team is a very essential thing in our neonatal surgical care. That is a very important thing. It was a good presentation that you're noting it down. That is very important, so that we come to know how many cases and what kind of cases are coming across. That is the thing.
False negative, two were false negative on Doppler, and solely relying on Doppler would have led to loss of more testes in our series. Follow-up was done at the end of 4 to 6 months. At follow-up, 19 testes which were salvaged out of 31 cases of torsion testes. 7 were considered as non-salvage, which had less than 40% preserved volume, whereas 12 cases were salvaged, which had more than 40% preserved volume with intact vascularity. Discussion. Ischemia duration of more than 12 hours had statistical significant impact on testicular salvageability in our study. And testicular salvage rate was 41% for who presented within 12 hours, and it was 3% for who presented more than 12 hours. And negative exploration rate of 62 is due to testicular appendage torsion and epididyma orchitis. Negative scrotal expiration rates are more acceptable than missing a torsion. Doppler had a positive predictive value of only 87%. Hence, emergency scrotal expiration is the only definitive diagnostic and therapeutic tool for acute scrotum in children. Thank you.
Recording in progress. Okay, may I ask you a few questions? Number one is, so what is your protocol if a child comes in the middle of the night with acute scrotum? Do you have Doppler then, or you will go in directly without doing a Doppler?
Actually, we always have a option for Doppler, sir. But when patient has presented less than 6 hours and when there are obvious signs of acute scrotum, and when we did not delay the time for surgery, we have directly taken up for surgery. Only when the patient presentation was more than 12 hours. In such cases, we went ahead with Doppler and then we took the patient for surgery.
And okay, then your salvage rate, you have told for within 12 hours, it is 41% approximately,
Yes.
right?
Yes,
So
sir, yes,
this
sir.
is with what is the follow-up duration for this salvage rate?
So 4 to 6 months, sir.
4 to 6 months. Do you think
Yes.
it is adequate?
Yes, sir. It
There
is
is
adequate to.
no scope of atrophy after that. Do you think that?
There can be chances of atrophy, sir, even after that.
Okay, that's all right. That's all.
Yes.
Pooja, do you know the type of deformity which you are presenting the, what is the cause for this torsion of testis?
Ma'am, there are various causes. One is bell wrapper deformity, wherein there is high investment of tunica vaginalis, which causes an axis. Yeah, so that has got more chances of torsion.
So that's why we do the opposite side
Side also contralateral.
because the deformity, yes, contralateral, yes, because of the deformity maybe in the both sides, yes.
Both sides,
okay,
yes.
good. Okay,
Thank you, Pooja.
Thank you,
Just
sir.
finished our presentation within the time. Now we are going. Rishikesh, are you there? Rishikesh, D7. Rishikesh Surya.
I don't think he has joined.
Yeah.
He's not responded on the group as well.
Raghav, D8. Raghav. D8, Raghav Maheshwari, are you there? Yeah. Please share your screen.
Am I visible?
Yeah, your screen is visible.
Okay.
You can start.
So, good afternoon, everyone. I am Raghav Maheshwari, first year surgery resident from Tata Main Hospital, and I'll be presenting a case titled An Airy Cyst on the Shoulder under the guidance of Dr. Shishir Kumar.
But Raghav, we can't see your presentation. Please share your presentation again. Yes. Okay, now we can.
Is it visible?
Yes, it's visible. Now start.
Okay. So good afternoon, everyone. I'm Dr. Raghav Maheshwari, a first year surgery resident from Tata Main Hospital, and I'll be presenting an airy cyst on the shoulder, which is the title of my presentation, under the guidance of Dr. Shishir Kumar, a pediatric surgeon at Tata Main Hospital, Jamshedpur. So as an introduction, bronchogenic cysts are rare remnants formed during the early stages of development of the mediastinum and the tracheobronchial tree, and are usually asymptomatic, benign, and are found incidentally on workup for presenting complaints of common illnesses with a predilection towards males. On the right, we can see a skygram of the chest showing a bronchogenic cyst. So a three-year-old girl was brought with a non-tender mobile soft cystic swelling over the left suprascapular region, measuring about 2 by 1.5 centimeters in size. A high-resolution ultrasonogram done of the lesion showed a superficial soft tissue lesion of size 22 by 7 millimeters in the region of the left scapula without any extension to the chest wall or mediastinum. An FNAC showed macrophages with few benign squamous epithelial cells, anucleate squamous cells, amidst a mixed, predominantly acute inflammatory background without any evidence of granuloma or malignancy. The patient underwent excision of the cyst under general anesthesia, which was followed by a histopathological examination of the excised specimen. The histopath revealed the cyst on the shoulder to be an extrathoracic bronchogenic cyst, and a CCT thorax was done postoperatively to confirm no missed developmental mediastinal remnants postoperatively. So after completely excising the cyst, it was sent for histopath, a slide of which under light microscopy is seen on the right. A histopathological examination showed the cyst wall being lined by pseudostratified focally ciliated columnar epithelium composed of columnar to cuboidal cells arranged in 2-3 layers, suggesting the possibility of an infected cyst of bronchial origin. On the right in the inset, we can see feather-like projections from the topmost layer of the epithelial lining denoting cilia and bronchogenic origin. The possible suggestion was bronchogenic cyst. It was followed up by a contrast-enhanced CT of the chest to rule out any mediastinal remnants. As a discussion, bronchogenic cysts are usually asymptomatic benign cysts and are found incidentally on workup for presenting complaints of common illnesses and account for 10 to 15% of mediastinal tumors. They are classified into 5 types according to their location: paratracheal, paraesophageal, hilar, and miscellaneous. This particular patient presented with a bronchogenic cyst on the left shoulder, which is itself a very atypical presentation of a bronchogenic cyst. So at third week of the embryo, the foregut undergoes dichotomous development and branches into the respiratory system and the foregut, primitive foregut. So the most important factor in diagnosis of a bronchogenic cyst is the physical examination, and imaging only aids in the diagnosis. Differentials include a branchial cleft cyst, a dermoid cyst or an epidermoid cyst, cervical thymic cyst, a thyroid cyst, or a lymph node which may be infected. It was difficult to distinguish this disease from other diseases by preoperative imaging alone. Thus, a histopath examination was critical to confirm the diagnosis. The bronchogenic cysts are typically filled with clear fluid, air, or hemorrhagic secretions, and due to the risk of malignant transformation and complications, surgical excision is the most effective method to treat a bronchogenic cyst in the head and neck. Once a bronchogenic cyst is suspected, surgical excision should be undertaken. So as a conclusion, bronchogenic cysts are extremely rare congenital malformation.
Raghav, you exceeded time.
So this was a bronchogenic cyst at an atypical location, and it was only confirmed by a histopath examination. Thank you.
Raghav, you can limit your. So you're repeating again and again the same thing. You're saying the same thing. So your slides has to be better, and you cannot copy paste the entire discussion. Right? You have to line one line. Be able to understand. When you describe the surgical procedure, and again the management was there, so you have to improve on this part. This is a very rare finding. Yes, we all have come across, and we have also operated since on histopathology. We have come to know it as a bronchogenic cyst. It has happened. So this topic is rare, but you have to make your presentations better. Okay. Okay.
If time permits, Dr. Raghav, have you had any other literature regarding this atypical presentation of bronchogenic cyst? If so, can you give me a hypothesis, embryologic, why it can occur in those rare areas?
This is the only one that I have come across, but during embryological formation, cysts maybe as age progresses, cysts are farther away from the mediastinum or the tracheobronchial tree, so it may be because of sequestration of these cysts to atypical sites like the neck or the shoulders.
So that would be, I think you will be publishing this. So that would be a hypothesis you need. Okay, if you try to publish it, you will need a hypothesis to think about it as well. Okay, that's all. That's all.
Thank you, Dr. Raghav. Now we are proceeding to the next presenter, Aishwarya Roy, T9.
Yes, I'm there, sir.
Yeah, we are able to see. Can you please share
Yeah,
your
sir.
screen?
Yes, sir.
Yeah, it is visible. Can you read full screen?
Yeah, sure, sir.
Yes. You can start.
Yes, am I visible, sir?
Yeah, you're visible and your presentation is visible. You can start.
Okay, sir. Thank you, sir. Good afternoon, sir. And Shubho Bijaya. I'm Dr. Aishwarya Roy, first year general surgery resident from Arjikar Medical College and Hospital. I am presenting this under the guidance of Dr. Pankaj Haldar, Associate Professor, Department of Pediatric Surgery. So here I present taboo strium treatment, unmasking anorectal malformation in adults who dodged doctors for years. Imagine a world in which the intricate design of the body can sometimes go slightly off script, presenting unique challenges from birth. Anorectal malformations are one such fascinating anomaly that arises from aberrant hindgut development. These malformations can be as minor as a misplaced anus or as complex as a missing rectal opening altogether, sometimes intertwined with urogenital anomalies. Early diagnosis through perianal inspection at or shortly after birth, checking for other associated anomalies, followed by staged operations, a diversion colostomy, anoplasty, and colostomy closure within 6 months to 1 year of age can yield the best cosmetic and functional results. Few patients appear late due to psychosocial constraints, which really pose a real management dilemma. Before I go into my case, let me talk about what is ARM. So ARM is anorectal malformation, that is abnormal development of the distal end of the intestine. Pathogenesis is disruption of normal fetal development, typically during the 4th to 6th, 7th week. Somewhere it is also written 4th to 16th week of gestation, but exact mechanism is not known. Multiple factors like failure of cloacal division, disruption of mesodermal development, genetic and environmental factors, molecular pathway, sonic hedgehog and WNT signaling pathways, etc. are responsible. There are multiple complications of untreated anorectal malformations like UTI, intestinal obstruction, fistula, colostomy-related problems, recurrent fistula, anal stenosis, poor bowel control, constipation, etc. Here there is a diagram that I have attached that shows different types of anorectal malformation in both male and female. Maybe it is very small, that is why it's not visible right here. But I can say that there are different types like non-opening, or there is abnormal fistula formation between different organs like bladder, vagina, with the rectum, etc. So here I'm coming to our case. Here we describe two cases of delayed presentation with anorectal malformation. One 14-year and one 16-year-old male presented to our general service surgery department, and surprisingly both of them has very similar history, even though they are not related at all to each other. Both of them had imperforate anus, for which an emergency colostomy was done by an emergency surgeon at a rural hospital, and then they were advised to attend higher surgical department, which they totally avoided due to psychosocial limitations and kept on hiding their problem. Later, after several years, due to some non-specific abdominal pain, they went to a general surgeon who referred them to our department of general surgery. We admitted the patients immediately, consulted with our pediatric surgeon department, and completed all investigations like distal cologram, X-ray of the lumbosacral spine, hemogram, etc. Then new anus formation was performed through posterior sagittal anorectoplasty, and patients were discharged 7 days after surgery in a healthy condition. 3 months after the initial surgery, the patients were readmitted for colostomy reversal, and they were again discharged after a few days in healthy condition, and currently they are doing really well. They are reviewing at our general surgery OPD regularly and having normal and regular bowel and bladder habits. Next, coming to the discussion on what is the implication of this case. So despite ongoing efforts, there are very few reported cases delayed presentation of ARN, particularly in developing countries, and especially in adult population. Late surgery and stooling practice at adult age have a detrimental effect on bowel and bladder habits. A delayed diagnosis is mostly due to misdiagnosis, non-institutional delivery, wrong advice by local healthcare provider, and low socioeconomic status of the family. A good collaboration is necessary between pediatric and general surgeons, as general surgeons are unfamiliar with such specialized surgeries like PSARP for ARM, and pediatric surgeons are concerned about disproportionately large adult organ with
Dr.
dilated
Aishwarya,
colon.
time exceeded.
Yes, ma'am. In order to raise public awareness, we also need to publish more of these cases in journals and on other platforms. So these are some places from where I have taken some references. And thank you so much for listening to me and giving me this opportunity to present here. Thank you so much. Really blessed.
Hello,
Sir, any questions?
Aishwarya.
Yes, ma'am.
With all of the conditions, Aishwarya, you are presented here. Thank you for that. Whichever situation we all are, we know that. Okay, it's great. And I hope you were scrubbed during these procedures. Were you there with Dr. Pankaj?
Yes, ma'am. In one of
You
the
have
surgeries, I was there because like I'm just a first year resident. So the first one I wasn't there because I wasn't allotted in that college, but in the second one I was there with sir.
Okay. I hope you got to learn a lot of things. Okay. And I think our situation gets better.
Yes, ma'am. We all hope
Okay.
that we get better, ma'am.
Okay. Thank you.
Thank you so much, ma'am, for having me.
Dr.
Thank you,
Vinay,
Aishwarya.
Dr.
Yes,
Vinay,
sir.
do you want to ask anything to Dr. Aishwarya?
No, sir.
Okay, I'll just ask one thing because you have both of them are doing very well. How do you assess continence and stooling pattern after the definitive surgery has been done? And yeah, that's all. That's all.
Yes,
Do you
sir.
have any idea? Yeah.
Yes, sir. First of all, like from history, whether they are having any kind of soiling or not, whether they are like complaining of like uncontrolled, elimination of fecal matter, that will be a like known from the history. And from per rectal examination, if we do PR, then the strength of the like anal muscle, like the tone of the sphincter can be judged. Like if there is incompetence, then it will be more dilated and.
So do you know about, can you name one scoring system, any one that you know of to assess the continence? Have you heard of any scoring system?
So
You
not
are
yet.
okay, what you are telling was okay, but okay, then go through it. That's all right. That's okay. Fine.
Thank you so much, sir.
Thank you, Aishwarya. All the best. And the next presenter is Aishwarya from Sri Ramchandra Institute from PEDS department. Aishwarya, are you able to? Yeah, please share your screen. Yeah, we are able to see your screen. Okay, you can start.
Am I audible, sir? My screen visible.
Yeah, it's visible. You can start.
Good afternoon, one and all. I'm Dr. Aishwarya, pediatric postgraduate from Sri Ramachandra Institute, Chennai. Today, I'm presenting a case on the topic TALL, post-asparaginase pancreatitis, complicated with pancreatic pseudocysts, under the guidance of Dr. Prakash Agarwal, sir, Professor, Department of Pediatric Surgery, Srihar. To begin with, L-asparaginase is a key component of chemotherapy for T-cell ALL. It inhibits asparagine, an essential amino acid which is needed for leukemia cell growth. It is known to cause many complications such as hypersensitivity, acute pancreatitis, hyperglycemia, and hypercoagulability. To begin with, we had a 15-year-old male child diagnosed with TALL and was treated with ICLE protocol, which included L-asparaginase in his chemotherapy regimen. During the delayed intensification phase, he had an episode of severe pancreatitis, which we were able to manage medically. Conservative management was done. He recovered after 2 weeks. He recovered after 2 weeks and chemotherapy protocol was restarted. Further, he was continued on maintenance phase of chemotherapy since December 2023. In June, when the child came for review, we noted that he had significant weight loss. He dropped from 54 kg to 46 kg, along with complaints of early satiety in spite of having a good appetite. In view of significant previous history of pancreatitis and symptoms of upper GI disturbances, we considered chronic pancreatitis versus sequelae of pancreatitis like pancreatic pseudocyst. We went ahead with the investigations. His CBC, LFT, RFT were normal. Serum amylase and lipase levels were elevated. We did an ultrasound abdomen for the child. We were able to locate a well-defined anechoic lesion measuring 8.8 cross 8.3 centimeter. We did a CT whole abdomen for the child. A well-defined thick wall large cystic lesion was noted. It was a pseudocyst of pancreas. Almost volume was around 300 cc, which replaced the distal body and tail of pancreas. I hope we are able to see it in the image. We consulted a team of pediatric surgeons. Since the cyst was huge, more than 6 centimeter, the child was advised to undergo laparoscopic cystogastroscopy, which the child did. He recovered over the next 2 weeks and is doing well. We restarted on the oral chemotherapy, and the child is tolerating chemotherapy also. The main point of discussion I would like to enhance is there are many case reports of L-asparginase induced pancreatitis in literature, but there are only 8 case reports reported so far with associated pseudocyst of pancreas. So hence, we would like to enforce that clinicians should be more vigilant for this complication also and consider timely pediatric surgery intervention to optimize patient outcomes. To conclude, laparoscopic procedure had more advantages for our patient because it caused shorter hospital stay, so less chance of nosocomial infection, lesser wound infection, and the patient was able to return to faster adjuvant chemotherapy, which optimized the clinical outcomes for the patient also. These are my references, which also stress the importance of timely pediatric surgery intervention in asparginase-induced pancreatic pseudocyst. Thank you for the opportunity. Thank you, sir. Thank you, ma'am.
Thank you, Aishwarya. So what is the procedure which we do for pancreatic pseudocyst? When do we decide to go in surgically?
Consider pediatric surgery intervention when the cyst is like symptomatic pancreatic pseudocyst more than 6 centimeter, ma'am.
Yeah. So, yes, the wall of the cyst. You mean the wall of the cyst to be 6 centimeter?
Yes,
the
ma'am.
thickness of the wall of the cyst. Yes, we
ma'am.
decide by that. So, how do you follow? By USG or do you need other investigation?
Ma'am,
Is it okay with ultrasound?
Intro of ultrasound we can use, ma'am.
You were there in the surgery? Were you there?
No, ma'am. Like we referred to the pediatric surgery team, ma'am. Like pediatric PGs, we are not inside the OT, ma'am.
Oh, okay. So we do a cystogastrostomy.
Yes, ma'am. Like I discuss with sir, ma'am. Sir told like greater curvature of stomach, the cyst will be open.
Thank you, Aishwarya.
Yes.
Yes, into the cyst wall, yes. And your animations and this, the presentation is very good.
Thank you, ma'am. Thanks so much, ma'am.
Okay.
I'll just ask one thing here. Do you have any other alternative other than going for surgery in this case?
So like other options were percutaneous drainage and or open surgical drainage.
Anything through a natural orifice? Through mouth, anything through mouth. And
for
whether
the like naso.
Yeah. Have you heard of endoscopic? Any endoscopic procedures for
ERCP, sir?
No, not ERCP. Okay, that's all right. Okay.
Thank you, Aishwarya. Chairpersons, please note she has finished within the time. And the next and the last presenter of this session is Kaushik, and he's from Kovia Medical Hospital from OBGy department. Kaushik, we are able to see your screen, and you can proceed. You can start.
Yeah. Good evening, sir. I'm Dr. Kaushika from OG DNB resident from KMCH. Today, I'm going to present a case report of congenital pulmonary airway malformation from a prenatal intervention to postnatal follow-up. A 32 years G6 at anomaly scan showing an echogenic cystic lung lesions with multiple cysts. This image showing the cardiac flow chamber views with largest cyst measuring 1 centimeter with CPAP volume ratio, which is an which is a prenatal predictor for outcome course of the diseases, shows in 0.63, with serial ultrasound follow-up shows increase in the cyst size and increasing in the CVR. At 27 weeks of gestation, we noted the largest cyst size measuring 2 centimeter with a CVR of 1.6. In view of increasing in the cyst size and increasing in the CVR and impending hydrops, the couples were explained about the need for prenatal intervention. Even though the cystic aspiration will decompress the cyst, but the risk of fluid reaccumulation limits its usefulness. Hence, we subjected the baby for thoracoamniotic shunt, and the shunt was placed at 27+3. And follow-up scan shows an inward migration of the shunt inside the thoracic cavity, and repeat shunt was done using an Harrison's stent with an echo tip, with enhancing echo tip, increasing the visualization under ultrasound guidances. With the repeat shunt was done, and the follow-up ultrasound shows decrease in the cyst size and decreasing in the CVR. Hence, we continued the pregnancy till 38 completed weeks and delivered the baby at 38 weeks of gestation to deliver a term 3.1 kg baby. Immediately after birth, the shunt was held by the baby's right hand. It could be often pulled out by the baby prior to birth. With immediately after delivery, baby is having retraction and tachypnea, for which the baby is put on CPAP. By 24 hours, the distress settled. It could be often TTN with postnatal X-ray shows an retained shunt inside the thoracic cavity with the tip of the shunt inside the set and the other tip in the pleural cavity. With the dextrocardia, minimal pneumothorax and transmediastinal herniation, and postnatal CECT shows a well-defined air-containing spaces with multiple loculated cysts with septations, which shows mass effect on the adjoining normal lung parenchyma and significant mediastinal shift and pneumothorax. And left upper pulmonary lobectomy done through left fifth space thoracotomy and ICD care. And the baby tolerated the procedure well, and ICD removed on 3rd day, sir. And the baby was discharged without any symptoms on 7th day, with histopathology shows an adenomatous CPAM with largest cyst type. And discussion, though it is a rarest occurrence which occurring in 1 in 25,000 live births, it consists of microcystic and macrocystic type, which microcystic types regress spontaneously or with antenatal steroids. This macrocystic needs evaluation and accurate diagnosis with prenatal intervention and systemic follow-up with meticulous surgery decreasing the morbidity. The same baby at the 1 year of age. Now the baby is 2 years, 2 months at present and leading a healthy life without any symptoms, sir. Thank you, sir.
Hello. So
yes, ma'am.
your factor for deciding for antenatal procedure was
Yes, ma'am.
just the diagnosis or the ratio?
Ratio, ma'am. Because the ratio, CVR ratio is increasing and the largest is also increasing, ma'am. In view of impending hydrops, we planned for prenatal intervention, ma'am.
Okay. It is a very rare case. Done. It is well done. Okay.
Yes, ma'am. Thank you, ma'am.
Excellent. I have no questions. Okay.
Thank you, sir.
Thank you, Aishwarya. Ma'am, sir, there is one candidate.
Do we have Ekta? Dr. Ekta?
Yes.
Is my
Okay.
presentation visible?
Yeah, it's visible.
Okay. Sorry for the previous technical glitch. I'm back again. So I'm Dr. Ekta, presenting the case of roaming knock-knees, a misleading presentation of parathyroid adenoma under the guidance of Dr. Santosh Kurpet from Department of Pediatric Surgery, Jawaharlal Nehru Medical College, Belgaum. So knock-knees has various causes in pediatric age group. It can be due to most common vitamin D deficiency, tumors, osteomyelitis. And in our case, the patient had knock-knees due to hyperparathyroidism, secondary to a parathyroid adenoma. And which this parathyroid adenoma has a straightforward excision once the diagnosis is confirmed. And hyperparathyroidism is usually seen in elders, most commonly above 40 years, and in females. And most common cause of hyperparathyroidism being a solitary parathyroid adenoma, incidence being about 85 to 90%. And in females, it is about 66, and in males, it is about 25 per 1 lakh men. And in case report,
from coming to my case report, here is a 13-year-old female complaining of bending of the knees and pain in the knees since 3 months, not associated with any fever, abdominal pain, flank pain, no fractures, no renal stones, any psychiatric symptoms, and no history of any radiation exposure or similar complaints in the family, and no history of any trauma. As you can see in the image, there is knock knees at the knee joint. And initially, the patient consulted orthopedician, and after the initial treatment of vitamin D and calcium supplementation, after 3 months, patient was advised MRI right knee, which was suggestive of marrow infiltrative disorder. Hence, was advised to rule out hematological malignancy. Hence, further referred to hematoncologist, where the patient underwent bone marrow aspiration and biopsy, which was suggestive of query Paget's disease. To be noted here, peripheral smear was normal, and then in query of Paget's disease, technetium 99 whole body scan was done, which also came out to be normal. And then patient serum ALP, calcium, phosphorus, and vitamin D was advised. Based on this interpretation of these levels, patient was further referred to endocrinologist. And endocrinologist advised a parathyroid hormone and calcium and phosphorus. As you can see, within a span of the 6 days, parathyroid hormone, the normal level, let me enlighten, the normal level being about 20 to 70 picograms per ml of parathyroid hormone. Here, from 152, it has raised to 2,381 in the span of 6 days. And calcium also elevated, and there is ALP also elevated, which is suggestive. ALP elevation suggests increased bone turnover. And then from endocrinologist advised a USG neck to rule out parathyroid adenoma, which was suggestive of a right parathyroid adenoma with increased vascularity and a predominantly hypoechoic lesion of 2.7 into 1.1 into 1.17 centimeters. And the normal bilateral thyroid status was there. Patient was finally referred to pediatric surgery, and where we have repeated a CECT neck, which was showing an oblong enhancing soft tissue lesion in the right tracheoesophageal groove, posterior to the right lobe of thyroid, suggestive of parathyroid adenoma. Preoperatively, thyroid profile was within normal limits. USG abdomen pelvis was done to rule out pheochromocytoma, renal calyx, and patient plan for excision of right parathyroid adenoma. Preoperatively, hydration was given, diuretics was given, and intraop excision of the gland. After the excision of gland, with for 10 minutes, PTH levels was sent after 10 minutes, which came down to parathyroid hormone came down to 280, initially being 2,800, now coming down to 280. Hence, confirming the removal of adenoma following the Miami protocol. This is post-op patient was observed for features of hypocalcemia and was managed accordingly. HPR was showing parathyroid adenoma features. Patient improved and was discharged on post-operative day 5. And parathyroid adenoma, coming to my discussion, parathyroid adenoma causes hyperparathyroidism, which can have features of involving bones, kidney stones, abdominal groans, and psychiatric overtones. And pathognomic of hyperparathyroidism is band keratopathy, which is not seen in this patient. And primary hyperparathyroidism can be due to adenoma, hyperplasia, cancer, adenoma being the most common cause. Most sensitive and specific test to localize parathyroid tissue is
you are overriding your time.
Can I have a minute, please?
Okay.
Yeah. With sestamides scan, and adenoma has a straightforward surgical excision. Diagnosis is confirmed by the Miami protocol, where there is parathyroid hormone fall of more than 50% preoperatively, and value drops in 10 to 15 minutes of the gland removal. And conclusion, genovalgum has various causes in pediatric age group. And hence, this patient roamed to about first initially going to orthopedician, then hemato-oncologist, and then going to an endocrinologist, and finally being referred to pediatric surgeon for her treatment. And hence, named it as roaming knock knees. And once identified, parathyroid adenoma has a straightforward excision of the gland of the adenoma. And to be this is a very rare case to be seen in children, usually seen in adults above 40 years and females. Thank you so much.
Okay, how long since you operated this child?
Yes, sir. Can you come
how long since you operated this child?
Sir, we have operated this patient in January 2023, sir.
So what about the initial complaint, knock knees? How are you treating them?
Sir, her only complaint was knock knees initially. After she finished her course of 3 months of calcium supplements, vitamin D supplements, and for right now for the knock knees, patient was advised surgery from the orthopedic side to correct the bend. Patient is still deciding on that. She has not undergone the surgery yet.
And can you tell me the mechanism by which this hyperparathyroidism with adenoma cause knock-knee? Do you know anything about it?
Yes, sir. The basic parathormone action is to increase bone resorption. Parathyroid hormone mechanism is to maintain the calcium level in the blood. So it will do anything to maintain the calcium level, and hence it will cause resorption of the bone. And then there was a bending of the bones in the knee joints, leading to the genu valgum in this patient. And there will be associated hypophosphatemia, ALP increase, which was seen in our case, and elevation in the parathyroid hormone.
Okay.
Yes.
Okay.
Thank you.
Okay, so just that your time was over. So the thing is, you can arrange your discussion. So you were repeating a lot of things because you were telling us, and the history was as such very typical what changes are occurring. So we can just reduce because you are losing points. So even if you end it, yeah, you lose points. So you have to arrange it in a better way. It was very well done. Okay.
Thank you so much.
Thank you, Dr. Ekta.
Thank you.
And I would also like to thank our chairpersons, Somak sir and Rupa ma'am. Dr. Tanmay, we will have a discussion and we'll announce the winner.
Yeah. Thank you, all the chairpersons. And with this, we come to the end. And I know lots of you are waiting for the results, and we'll shortly announce it. And I must say that all the presenters who had come and put in the hard work have done really good justice to whatever they presented. And all the discussions and all the sessions were really good. And the chairpersons have complimented, and there was a bit difficult also to decide the results in some instances. So we'll discuss that. And first, congratulate all of you for presenting so well. Now I'll hand it over to first Ramesh sir, President IAPS, and then Vikesh sir, General Secretary IAPS, for their remarks about the conference today. Ramesh sir, over to you, sir.
Yeah, this particular program has been a dream for me, basically. I mean, I wanted to involve all the pediatric PGs, general surgery PGs, and all allied PGs, maybe OG PGs also. And I'm so glad that it materialized eventually. I should thank the entire team of you guys, youngsters, who have taken over that moderation without any hiccup, actually. We did very well. And then I also thank Vikesh for entrusting this great responsibility on you, because it's a great learning exercise for us as well as you guys. And it's a well done, great show by all of you. So I think a big applause is due for all of you.
Thank you so much, sir. And I think with the vision of you and Vikesh, sir, IAPS has been growing leaps and bounds. And it's really heartening to see the youngsters also getting an opportunity. And we are trying to involve other fraternities as well, because overall the patient management goes this way. Vikesh, sir, your closing.
Yeah. Thank you, Tanmay. Formally, I would like to thank you, Tanmay, Vidya, Abhirami, Vinay. You guys never.
Vikesh.
Yeah, whatever. Yeah, so you guys made me so comfortable throughout this process that I had to do nothing actually to organize this program. So that was really great of you. One thing which not surprised me but amazed me rather is the enthusiasm which these participants were having, and the level of preparation which these guys did. They are like broad specialty students, and still the level of preparation which these guys showed, it was really amazing. I'm really impressed with the work uh, these guys have done in presenting, preparing, and ready. They were ready with the answers. They anticipated the questions, and very good discussion happened because of enthusiastic chairpersons we were having. Thank you very much, everyone. And now over to you, Tanmay. You can take it further to announce the awards.
Thank you so much, sir. And just a few more minutes before we get the results compiled for the last session. So in the meanwhile, I'll request
We can have inputs from postgraduates if they are there. Yeah.
And we can also have inputs from, I think, Dr. Abhirami, Dr.
Yeah.
or Dr. Vinay, if they want to share some of their remarks on the today's conference. And then we can have some of the PG's experience and then when we won't take much of time, Then we'll announce the awards. Yeah. Abhirami, you want to say something?
Thank you for the opportunity, first of all, Sir Vikesh sir and Ramesh sir. And this is, I think IAPS this time has thrown lights on young pediatric surgeons and making us chairpersons to moderate and coordinate sessions like this is truly a great opportunity. And it was nice to see postgraduates from several departments, not only general surgery and pediatrics, obstetrics also, to completely involve in the subject, and general surgery PGs giving their insights about pediatric surgery, because I don't remember having so much of knowledge of pediatric surgery when I was in my general surgery. So I think I should thank the organization and IAPS team to give this opportunity.
Thank you. Vidya, you want to share something?
Nothing much. I would like to thank you all for this opportunity. It was a really nice experience, and it was amazing how much pediatric surgical knowledge all our broad specialty colleagues had, and the enthusiasm that they had today. It was really nice, and the spectrum of topics that was chosen also was really nice. So it was a good session to be a part of. Thank you, sir.
Thank you, Vidya. And I think if any of the PGs can share their experience, how was it presenting something which is a niche topic? If any of the PGs have any experiences to share, just final few more minutes.
Feel free. We are not your professor. You can feel free to point out if we are supposed to improve something, then you please let us know. Next time we will try to improve upon that.
I think the residents are saying ki sir results batao.
We should pledge by pediatric surgeon to attend what someone is writing something. Okay, before you announce the result and everyone quit the meeting, can everyone switch on the video and we can have few pictures here?
Yeah, we can have a group photograph.
Yeah. Chairpersons made the session very interesting, very good discussion.
Thank you.
Thank you, sir.
Thank you, sir.
Someone is in party mode.
पार्टी शाम को करना प्राइज मिलने के बाद. Tanmay, you are taking the picture?
Yeah, I am taking the picture. Everyone can put up a smile. 1, 2, 3. Okay. Do we have more? Yeah, wait.
Yeah, just give some time to everyone.
Yeah, 1, 2, and 3. Okay. Okay, I've got the picture.
Thank you.
Okay.
So I'll just request the chairpersons for the last session, Dr. Vinay, Dr. Somak, Dr. Rupa. If
Yes,
you're done.
yes, we have done. Vinay, please announce. Dr.
We can
Vinay?
start with the session 1 first. You can just post in the group and
You
then
post in the group.
So okay. I think Vinay has posted in the group. Wait, I'll just.
Do you have can you do the slide share?
Okay.
Tanmay?
Yeah. Vidya is doing so.
Vidya has
Yes,
prepared
okay.
the beautiful design of the results.
So Vinay just
Yes, ma'am.
post in the group.
Yeah, ma'am.
Yes, for the first
okay.
session, which
I'll
was
post it in the group.
gastroenterology, we have 2 awards, and there was a very tight competition. It was difficult to choose. That's what Dr. Abhirami told me. And the results, please share it, Dr. Vidya.
Yeah.
The first prize goes to Dr. Janvi Sirwani from AIMS Bhubaneswar. And the second prize goes to Dr. Jaya Sai Monica from Dr. B.R. Ambedkar Medical College, Bangalore. Congratulations to both of you. Are you guys there?
Show yourself if you are there.
Congratulations.
Yes, sir.
Congratulations.
Congratulations.
Well done.
Thank
So
you,
first
sir.
prize will get 5,000 rupees and second prize will get 3,000 rupees for all 4 sessions.
Oh, great. Amazing. So we can fix a deal for meet with them. And for the next session, which was on pediatric thoracic surgery, again a close competition between the winners and the runner-up. The results are: the first prize goes to Dr. Jaykrit Patil from SRIHER Chennai, and the second prize goes to Dr. Kritika from Sri Ramchandra Medical College, Chennai. Congratulations to you guys.
Thank you so much, sir. I'm really thankful for the opportunity to have to gotten to present here. Thank you.
So you presented very well, very well. Both the papers were really good. Congratulations.
Thank
We have Jaykrit also? No. Okay. Moving on to the next session. It was on pediatric urology, and the first prize goes to Dr. Satyamurthy Aruna from SRIHER Chennai, and the second prize goes to Akanksha Mehra from Netaji Subhash Chandra Bose Medical College, Jabalpur. Congratulations to both of you.
Congratulations.
Thank you, sir. Thank you for providing the opportunity.
Really, really nicely presented. And the last session, the winner is Dr. Abhirami, and the second prize goes to Dr. Kausiha. Congratulations to both of you.
Very
So
thank you, sir.
we
Thank
have
you, sir.
another Abhirami, another superstar with us. You know, Abhirami is a celebrity. All of us are sitting with Abhirami and we feel like we are sitting with a celebrity. Social media influencer.
So with this, I think we come to the conclusion of today's entire conference. And for those who could not make it, I'll like to tell you that you guys presented really well. And it was a very close call in all of the sessions. So it is not like that you lost. There are things that you may learn from here. There are things you may want to improve on your presentation skills, or especially on finishing the presentation on time so that you can earn more marks on that front, because there were papers who were really good, but then they didn't finish on time. So they lost some important marks there, and which made it difficult for us to choose the winners. So congratulations to all those who couldn't make it to the list, but then who presented well. And with this, we would like to conclude today's session. Thank you again to IAPS leadership, Dr. Ramesh Babu sir, our president, and our general secretary, Dr. Vikesh sir, and to all the fellow moderators and the chairpersons who made this event a great success. Thank you so much.
Thank you.
Thank you.
Thank you, sir.
To stop the recording.